call this meeting to order. Welcome to meeting number 116 of the House of Commons Standing Committee on Health. Before we begin, I'd like to ask all members to consult the cards on the table for guidelines to prevent audio feedback incidents. Please take note of the following preventative measures in place to protect the health and safety of all participants, including the interpreters. Please use only the black approved earpiece. The former gray earpieces must no longer be used. Please keep your earpiece away from all microphones at all times. And when you're not using your earpiece, place it face down on the sticker placed on the table for this purpose. Thank you for your cooperation. Pursuant to the order of reference adopted by the House of Commons last night, the committee is commencing its study of Bill C-64, an act respecting pharmacare. As was indicated in the memo that was sent out this morning, I'd like to remind members that amendments to Bill C-64 must be submitted to the clerk of the committee by 4 p.m. Eastern tomorrow, Friday, May 24th, 2024. It's important for members to note that, pursuant to the order adopted by the House yesterday, the 4 p.m. deadline to submit amendments is firm. This means that any amendments submitted to the clerk after the deadline and any amendments moved from the floor during clause-by-clause consideration of the bill will not be considered by the committee. Colleagues, we also have a budget for the study of Bill C-64 that I propose to present to you after we hear from all the witnesses this evening. But without further ado, I'd like to now welcome our first panel of witnesses. We have with us Honourable Mark Holland, Minister of Health, and accompanied by officials from the Department of Health, Michelle Boudreau, Associate Assistant Deputy Minister, Strategic Policy Branch, and Daniel McDonald, Director General, Office of Pharmaceutical Management Strategies, Strategic Policy Branch. Minister Holland will be with us for an hour, and the officials will stay on until 5 o'clock. Without further ado, welcome to the committee, Minister. You can now go ahead with your opening statement for the next 5 minutes.
Thank you so much, Mr. Chair, and I'm just going to start my own clock here if I can. Sorry. There you go. We'll start my time now, if that's okay. Thank you, Mr. Chair. It's such a pleasure to be here with the committee. J'apprécie énormément.
I appreciate all the work that this committee does. It is so important, especially for such an important issue our country is facing. People have to be able to have access to the medication that they need, and I think that this is a fundamental issue within our health system. From the outset, I would like to thank the member for Vancouver Kingsway for their work.
Example of how when we work together as parliamentarians and seek solutions to the difficult issues that are in front of us, we can find solutions. And I want to also thank the Now Health critic and member for Burnaby South, who is the House Leader, who I've had a chance to work with, both as a House Leader and as a Health Minister in his different roles on this, and thank him for his work. And of course, within our own caucus, the member for Brampton South, who is really been extraordinary in her advocacy. And of course, there's so many, I could use the full 5 minutes. But I'm going to focus today on drugs. We can talk about all the things that we're doing on health, but let's talk specifically about medication. You know, there's 1.1 million Canadians who aren't insured. And about 1 in 5 who are underinsured. In a very practical sense, that means they don't have access to medicine they need. Now, today in question period, Mr. Chair, we were talking about your home province of PEI and the difference it makes for the folks, for Islanders, to be able to afford their medication, and how critical that is, not just as a function of affordability, but really as a matter of dignity and a matter of prevention. If somebody doesn't, and let's just take diabetes in the first example, and some folks ask why diabetes. This is so fundamental to stopping so many other chronic diseases and illness. Do you know about 70% of chronic disease and illness are preventable? So we're taking historic action to deal with the crisis of the now in primary care and making sure people have access to the doctor and nurses that they need, that making sure that we're upstream so that somebody doesn't get sick in the first place is so critically important. When somebody has access to the diabetes medication they need, what does that mean? It means that they don't wind up with heart disease or a stroke. They don't wind up with a loss of a limb or dying. That's fundamentally important as a matter of social justice. It also is fundamentally important as a matter of savings. So we know that about 25% of folks with diabetes right now saying that cost is a major factor for them in sticking to a regime where they take the medication that they need. So you could focus on problems and critiques, or you can focus on solutions. That's what this bill does. It says, let's work with provinces and territories on creating a baseline. So when we're looking at that formulary, that's a minimum. It's not a maximum. Let's be very clear that everything that we're doing here is additive. It's working with provinces, that nobody's going to lose coverage. This is all about expanding coverage and making sure that patients have choice and that they get the medication that they need. And let's talk about sexual health for a second as well. We need to have a conversation in this country around sexual and reproductive health. To be able to say that every woman in every part of this country has the ability to choose the reproductive medicines that they need to take control of their reproductive and sexual health and futures. And to me, that is fundamental, and I hope sparks a general conversation about sexual health in this country and about sex being something that is affirming, that makes you grow stronger, and not something that is used as a tool for shame and pain and hurt. I look at this plan, and I want to say there are people who say, well, it's too much to hope for. You know, I was saying that today in the House. Don't hope for dental care. Don't hope for pharmacare. You just give up. Go away. Well, they said that about dental care. In 3 weeks, yesterday at noon, we crossed 100,000 seniors getting dental care. And to put that in perspective, when I was in Vanier talking to a denturist, about a patient for 41 years had the same set of dentures. Next week, she's going to be getting a new pair of dentures for the first time. That means she isn't crushing food in her mouth with plastic plates. She's going to be afforded the dignity of teeth in her mouth. This is real stuff we're doing. And there are people right now waiting for the contraceptives they need for their sexual and reproductive health. They're waiting for the diabetes medication that they need. Talking to Sarah in a clinic here, in a diabetes clinic, about what that's going to mean for people avoiding illness, for seeing patients who are reusing syringes and getting blood-borne diseases because they don't have access to it. This opens the door for us to negotiate with provinces to make sure that everybody gets that coverage. It's going to have a huge impact in terms of dignity, social justice, prevention, and cost avoidance, and I am exceptionally excited to talk about it today. Thank you, Mr. Chair.
Thank you, Minister. We're now going to begin rounds of questions, starting with the Conservatives for 6 minutes. Dr. Ellis.
Thank you very much, Chair. Thanks, Minister, for being here. You know, you talked about access to primary care. Can you tell the committee how many Canadians do not have access to primary care?
It's high. It's, of course, regionally dependent, but far too many Canadians don't, and that's why we're working on these agreements.
Across the country, Minister, how many Canadians don't have access to primary care? You know the number.
Well, it varies, and sometimes it's difficult to know, actually, because the circumstances are too opaque. We're missing a lot of the data that we need in health to be able to give precise numbers. So they're best guesses, but the number is too high, and I've seen a lot of numbers all over the map.
Minister, you're too afraid to say the number because under your watch it continues to increase. Is that not true?
Well, no, actually. Under the last 10 months, we've made huge progress. On my watch as health minister, we've signed 26 agreements, moving forward with $200 billion in funding. And I think you wouldn't find an association or an organization that represents nurses, doctors, personal support workers who isn't saying we're making tremendous progress and have over the last year.
Well, it's interesting, though, Ministers, because you've refused to give a number, but now you're telling Canadians that you've made progress. If you can't even count the number of people, how can you tell that you've made progress?
One of the things that we did in the agreement that I think is critically important is put common indicators across the country and prioritize health data so that we don't have that level of opaque nature to our health system. I think that we have provincial and territorial governments. It's essential that we have common indicators so that we can have clear and concise answers to these questions. So that was one of the things we built into that.
Let's just give a number. How many Canadians do not have access to primary care? Just a number. How many million?
Too many. We don't
no,
know the number.
that's not a number.
Well,
Too
we
many
don't
is
know
not
the
a
number.
number.
I've tried to explain that we can't. It's an
Everybody knows
unknowable
the number,
because.
Minister, except you.
Well, if you know the number, then say it. And where does it come from? Can you
So-
cite the source?
Thanks very much. Maybe I'll try one of your associates here. Mr. McDonald, do you know how many Canadians don't have access to primary care?
Per the minister's comments, I mean, that's information that's being collected pursuant to the agreements that have been signed.
So here we are. We have, and maybe Madame Boudreau, could I ask you the same question? How many Canadians don't have access to primary care?
Thank you for your question, Mr. Chair. I wouldn't be able to add anything further.
So what you're telling me is we have 3 officials, including the Minister of Health, who have no idea how many Canadians don't have access to primary care. Wow. This is going to go a long ways to helping Canadians then. How about this, Minister? Semaglutide. Why is it not on your list of medications?
Well, what we did is create a base. So one of the things when we're negotiating with provinces is to say this is just a floor to make sure that we have for those who are uninsured or underinsured, that we have a floor. So, we're absolutely open to both the committee's comments and negotiations with provinces to be additive. I would say that the list that you see is an absolute minimum, and I would expect there will be no final list that doesn't include more. So if there's things you think should be on that list, I'm actually quite interested in having that conversation. Hopefully it would mean you support the legislation.
Yeah, I don't think we need to worry about that because it's bad legislation. It's bad for Canadians. Can you tell Canadians how long it takes in Canada on general from first launch to public reimbursement for a medication?
Well, again, varies by province, but again, I would take it back. I hope that you won't just summarily reject the idea of helping people who are uninsured get medicine. I would ask you, if not
Minister,
this
I don't
plan,
think
what
that
is
was my
your plan,
question.
sir? So there's
I think that my
1.1
question-
million
excuse me, Chair.
uninsured Canadians.
I believe,
Could you tell us what your
Minister,
plan
that my
is to insure
question-
those folks? To make sure that
You
people
know
who
what,
don't have
Minister?
medication have medication.
You'll
What
have
is
your
your
chance
plan,
to
sir?
ask me questions at some point when you're sitting in the opposition. But can you tell all Canadians the number of days from global first launch to public reimbursement, how many days in Canada?
Again, when you're talking, depends on the medication, depends on the jurisdiction. But I would put it back to you. If you were going to vote against something, my preposition would be that you have to explain what you're going to do in its place. So if you have all of these folks who have no insurance and no medication, it's a pretty simple question to ask back, what are you going to do in its place? And you say you have no answer, then I would say, why are you voting against this?
No, I didn't say I didn't have an answer. You're the person who's given me, I've asked you 2 questions now, simple numbers, which you do not know the answer, nor do your officials. Third question, simple number, let's try another one. Percentage of new medications available by OECD country, 460 new medicines launched from 2012 to the end of 2021. How many are approved in Canada? What percentage? Just the percent.
Yeah, I'll just be straight with you. This is what is your purpose? Like, what are you trying to ask? Like, I understand you're trying to play a gotcha game here instead of, I'm trying to talk about people who don't have medicine, and you seem to be lost in some kind of partisan, weird thing that you're doing. Do you have a plan for people to get medicine, or do you not? And is this an attempt to obfuscate the point that you don't have a plan?
You're trying to do, we can talk about those. But what we're asking is simple questions on behalf of Canadians when we know.
No, I'm just curious. What's your point? Do you have a point?
I have lots of points. Well, let's start with the first point. You have no idea what you're talking about. Second point is Canadians wait the longest time in OECD countries for approval of medications, which you clearly have no clue about. We're back to that again. Sadly, the last time you were here, you had no clue, and you remain clueless, obviously. The percentage of new medications available in Canada, 44% of 460 medications. What that means is despite the fact that you want to go out and announce things that are untrue and not even happening, the system that you have, the regulatory system that you, sir, have control over, is failing Canadians. You had an opportunity to change that. You have chosen not to. You have chosen to attempt to keep yourself in power with your NDP costly coalition partners by creating something that already exists at provincial levels.
That's your time.
Thank you very much, Chair.
If you want an answer, okay.
I think I've already provided the answer, Chair.
No, hopefully one of somebody else will allot you some of their time to respond. I think that would be the fair thing to do. Mr. Yakvi now for 6 minutes, please.
Thank you, Chair. Welcome, Minister. I think it's shameful the behavior we just saw from Mr. Alice, where we're trying to have a thoughtful conversation about a very important piece of legislation that is going to make an incredible impact on the lives of Canadians. You don't have to agree with everything. The idea behind a committee meeting is to have a analytical discussion as to how we can improve a piece of legislation, not get into political, rhetorical diatribes as we saw. I'm personally very excited to see this piece of legislation. I've spent my time working at the provincial level in the Parliament in Ontario, where we brought in a farmer care legislation, a program called OHE Plus. I was very disappointed when I saw the Conservative government of Doug Ford gut that legislation, denying so many Ontarians access to important life-saving medication. So I'm thrilled that at the federal level, we are coming to legislation. Can you share with us, if this legislation passes, what are the next steps in terms of engaging the provinces, the territories, and the Indigenous peoples in rolling out this particular program, and the work that you're doing pursuant to this legislation, if passed, to ensure that all Canadians get access to diabetes medication and contraceptives?
Well, thank you, through you, Mr. Chair. Thank you very much for the question. Yeah, I mean, I think in the first order, what I hope, and this is why I was pushing back, is we have a very serious problem. And that problem is that there are a huge number of Canadians who don't have drug coverage. And so, you know, if we're discussing how we address that problem, I think I'm totally open to different ideas. I mean, I think this process was indicative of that. We had two different parties with two different ideas, try to come together and find common ground. And if other parties have other ideas, then I think it's important to talk about them. Frankly, if they have no idea and they just think people should continue to be uninsured, then yeah, I'm going to point that out. And I think that's important to highlight. And, you know, trying to obfuscate behind some kind of weird strategy, I don't think is appropriate. What I will say in terms of the next steps, because this is critically important, is that we've already started those. There have been very productive conversations with every province and every territory. And they really have set aside partisanship to ask in each province and each jurisdiction, how can we work with that jurisdiction of authority to augment and make better what they have. So we have provinces that are leaders, right? So let's acknowledge Quebec and BC, Nova Scotia, and Manitoba particularly, which are really taking leadership in this area. So we want to see that to be able to go further, right? To be able to work with leaders, to be able to expand our circle of action. And what's exciting about that is there's an example of parties, you know, governments of all political stripes who recognize that diabetes and contraceptives are not something that we should be crossing swords over or trying to score political points, that it's really how do we get the medicine to people who need it and how do we talk about solutions. And so it could be quite frustrating where I'm talking to provinces about solutions to be curtailed from that. But and then I would add as an additional measure, because obviously to really finalize those conversations, we need the House to adopt this so that we can go and finish those conversations. But then I would turn to the non-insured health benefit, because you were asking, and I think very importantly, about Indigenous peoples. And I think this is an important opportunity to also take a look in conjunction with what we're doing at the non-insured health benefit and consider its efficacy. We want to make sure that everybody has access to the medicine that they need. That's an iterative process, and it has to be taken a step at a time.
So in terms of next steps, what you are working at and what you foresee are bilateral agreements. I'm assuming that would provide for the actual delivery and payment of those medications. So, for example, if I'm a Canadian that's uninsured and don't have access to these medications, I'm able to walk up to my local pharmacy and use my provincial health card to get access to, let's say, diabetes medication if I need it?
Yeah, I think that's a fair characterization. I mean, we have to work it out for each province, but the idea is that you would have choice. So for somebody who has existing coverage, you can continue to use that coverage. For somebody who doesn't have coverage or is underinsured, this would give them a path towards coverage. Because there's a lot of folks who are underinsured, right? So you can be somebody who only has 70% coverage of their medicine, as an example, who can't afford that 30% copay, which means they're not getting the medicine they need, which means that they don't adhere to that regime of taking that medication, which means they wind up with a chronic disease. They wind up in our hospital system. They end up costing us an enormous amount of money. So it's more than just social justice. So it's critical that those people have access to a choice. This is what this is going to do. It's going to open up a choice about whether or not you want to use your existing insurance or whether or not you want to go with a single-payer universal system.
So talk to me a little bit about choice, because it's important, because there are few out there who are trying to relay a point that somehow this is going to get rid of a private insurance that someone may have, and this will be the only option that you can, by which you can get diabetes or contraceptives. Can you assure Canadians what that choice looks like and how, if they choose to maintain their private insurance, they can do so?
Yeah, 100%. It's incredibly important that we don't allow misinformation to fill this space. This is about adding folks, about expanding coverage, making sure that folks who are underinsured and folks who need access to insurance get it and get the medication that they need. It's going to be delivered through a single-payer model.
Thank you, Minister. Ensuite, c'est le tour de Monsieur Blanchette-Jonca.
Mr. Blanchette-Jonca, you have 6 minutes. Thank you very much, Chair, and I'd like to welcome the Minister. Minister, the Bloc Québécois is all in favor for helping people who are sick get the health care they need. And they're also in favor of a pharmacare program. You know what the Quebec government and the Bloc Québécois positions are the same. My question for you is this. Have you had a discussion with Mr. Christian Dubé, the health minister in Quebec? And if so, what did he tell you? Yes, absolutely. Thank you for your question. You're right. It is absolutely essential that we work within a spirit of cooperation with the government of Quebec. The government of Quebec has done a considerable amount of work in that area on the issues of access to medication for all Quebecers. And it is our intention to work directly with Quebec in order to add to that system. It is not our intention to create a separate system. It is to add to the current system. Minister, concretely speaking then, what did the Minister of Health, Christian Dubé, what did he ask you to respect in his province? Well, we need to make sure that we respect jurisdictions. And I must respect Quebec's jurisdiction. So within that process, that is clear. What we want to figure out is how the Government of Canada can work with the Government of Quebec in order to add to services, for example, for people with diabetes or for women and contraceptives, because the needs exist. And so I think we can work in a cooperative spirit and a respectful spirit. So that I'm sure I have understood, I'm just going to quote the minister. He said, we have no problem to adding money to our pharmacare program, but it must be unconditional. It is not up to them to decide what the best coverage is for Quebecers. Now, Minister, does respecting include respecting Quebec's government to turn down a program that it may already have for 30 years in Quebec? Well, there is no intention on our part to not respect Quebec's jurisdiction. This is a way of, or this is what we want to do is make sure that everyone has what they need. Contraceptives, diabetes, we're not just talking about medication here. So we want to be able to act in terms of what people need, in terms of the devices that they need, the medical devices, and we want to make sure that their needs are met. So we agree on the needs. But what I want to know is how you want to proceed. Do you agree that Quebec should be able to withdraw with full compensation unconditionally from that pharmacare program? Well, when I speak to Mr. Dubé, there isn't really an issue or a program or a problem. We're talking about bilateral agreements, and there is a spirit of cooperation. Well, then I'm going to put the question another way. Yes or no? Okay, so that's your choice. Do you agree that Quebec should be able to withdraw with full compensation from this new pharmacare program? Minister, it's a yes or no question. Well, just allow me to explain. You're using the word conditions, and we're not talking about conditions. It's finding a common goal and working together. So we have federal goals, of course. Those are in the bill, but we want to be able to find our common goals. So I don't really agree with your use of the wording. So that's why I'm not responding directly to that. Well, you're refusing to respond to the question. And that's an issue of respect for Quebec's will and for the government of Quebec's will. So we are taking note, and then we'll see what happens within negotiations. But I'm just going to continue here. You must understand that the Quebec government already has its own pharmacare program and has had that program for 30 years. You actually copied its model for the daycare program. So what we're asking you today, and it's a legitimate request, we already have our own model. So we want to have our money and manage our own program, a program that we've had for 30 years. Quebecers already have a program and a system, and they pay for that system. They don't want to pay twice to the federal government for a new program. So what we're asking is, would you agree that Quebecers who already have a system be able to take that money from the federal government because they pay taxes to the federal government and then be able to withdraw unconditionally? So they want to be able to have that funding to be able to expand their own program. That's my question. Well, when there's a conversation about federal money and about federal goals, it's absolutely essential to be able to speak with each other and find our common goals together. So it's not an issue of jurisdiction here, not at all. In terms of this bill, and in terms of our responsibility, it's what we need to do is find common goals. So in my opinion, we're talking about the same things, and I don't have a problem communicating that to Minister Dubé. I have no problem with Minister Dubé on that issue. Well, the one thing I want you to understand is that the government of Quebec already has its own system, and the Quebecers pay for that. So if Quebecers are going to be paying for a federal program and they don't get that money, then they're paying twice. So we're asking you to respect that. That's what you need to understand. Well, what you have to understand is that there's no federal program for that. We are going to work directly with provinces and territories in order to be able to use this system to provide the medicine that people need. So the government of Quebec is a partner, a true partner in this process, and it's very important that we find together our common goals. That's all your time.
For 6 minutes.
Thank you very much, Mr. Chair. And I did want to underscore the important historic nature of this hearing today. 60 years ago, Tommy Douglas, first leader of the NDP and the father of Canadian Medicare, helped to push through the House in a minority parliament universal health care. And now we're back 60 years later. Tommy Douglas's intention was always to move from universal health care to universal pharmacare, because the reality is every other developed country that has universal health care also has universal pharmacare. So this is a historic hearing. And I certainly wanted to thank many of the organizations that have brought this to being: Canadian Health Coalition, the Canadian Labour Congress, Canadian Federation of Nurses Unions, Council of Canadians, and so many other groups that have been pushing for years for this start of universal pharmacare. And so it's a historic day. And I wanted to thank you, Mr. Chair, for giving us adequate notice. We've known about this motion of instruction of the House for weeks, of course. We knew because of your memo last week. We had a week and a half to prepare for today's hearing. Appreciate the minister being here, and a week and a half to prepare amendments. I do note that my Conservative colleagues have not asked a question on the legislation yet. I hope they actually took the week and a half that you gave them to read the legislation. Mr. Chair, I would like, through you, to ask the Minister of Health then a following question about some of the clauses of the bill. First off, Section 8, the Clause 8, which talks to a national formulary. How do you see this developing as a national formulary that is required once we pass this bill, as you know, to be put into place 1 year from now?
Well, thank you very much. And of course, the national formulary, and it's one of the reasons that this bill, we've also announced the establishment of Canadian Drug Agency and put dollars forward to that so that national formulary can be developed independently by subject matter experts to list that and to have that national formulary. And I agree that's critically important. I was remiss in my opening statements, although I think I spent a minute and a half saying thank yous, but you're really right. This has been something that has been advocated by so many different organizations and groups, and you're correct to acknowledge that, and I want to acknowledge that omission.
I want to move on to Clause 9, Section 9, which talks about the national bulk purchasing strategy. As you know, Mr. Minister, we've seen countries like New Zealand using that bulk purchasing, reducing the cost of pharmaceutical products and medication that Canadians depend on by up to 90%. You have that, again, a timeline of a 1 year anniversary. How do you see that strategy being developed to meet that 1 year deadline? And what do you think? Have you done studies internally to know what the difference would be in terms of the cost to Canadians of medication?
Well, we know that just the action that we've taken so far is saved about $300 million a year. So we have coordinated bulk purchasing. That doesn't include private purchasing, but we have coordinated a lot of national purchasing through provinces and territories and working with them. That's saved about $300 million a year. It's a very significant amount of money. It's made our drugs much more competitive. So much so that we had the crisis with the United States looking to import our drugs. But we have more work to do. And the exact quantum of how much we can save is difficult to say. There's been a lot of different estimates, but I can say that it is significant, and that when I talk to private insurers, they acknowledge that the ability to move to one common bulk purchasing program has the opportunity to save consumers an enormous amount of money.
Makes you wonder how anybody could oppose that, right? Lower cost, more medication available. Finally, I wanted to ask you to comment on Section 11, the Committee of Experts. Again, deadlines are very tight, 1 year, so that's why I think we've had so many people and so many organizations across the country urging us to move on this. It's been unfortunately, this bill has been unfortunately blocked in the House for months, but now we're finally moving forward, which is wonderful. With that 1 year time frame, the deadline that is tight, how do you perceive the Committee of Experts reporting back to you and to the House of Commons?
Well, thank you, and through you, Mr. Chair. Yeah, I mean, the need is urgent, right? So the blocking of the bill is problematic because people desperately need these medications, and so it's important that we act expeditiously. With respect to the Committee of Experts, the intention would be to name immediately the folks who would populate that committee, and for it to be able to report back, and so that we can get clear and concise information around costs and options on the path forward, because while this work we're doing now is essential in the area of diabetes and contraceptives, we know there's a lot more work to be done. And so that committee is, I think, going to be very important in instructing costs and process in terms of the way forward.
The final question for this round is a constituent from Burnaby, BC, Amber. She's paying $1,000 a month for diabetes medication that keeps her alive and in good health. What does this bill mean for people like Amber who don't have insurance, who struggle to pay for their diabetes? And what would it mean if this bill continued to be blocked and she didn't have access to the solutions that are provided for in the bill?
Well, to be very direct, and you see it going to diabetes clinics, where patients like Amber are forced into choices of do they pay their rent, their groceries, or their medicine. And often medicine is what drops. And what is so tragic is that same clinic will see the person return much later with an improperly managed condition like diabetes, where they're in a terrible state, or where they wind up with a terrible chronic disease or illness. And seeing something like that for Amber that is entirely preventable, I don't think we want to live in that kind of country. You know, if 12-year-old Raina, she was at the announcement of this, and she's an advocate, who's a kid who's got diabetes, and said to me, no one should be in this country and not be able to afford their medicine. And sometimes, you know, when somebody's young, they can put something so clearly. And I find it a hard thing to be able to disagree with Raina or with Amber that they deserve to be able to get their medication.
Thank you, Minister.
And I think if the answer is that no, not this, then it's a fair question for Amber and Raina to say, well, then what?
Thank you, Minister. That's all the time for this round. Next up, Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to the Minister for being here. So, is there anything in this legislation that will prevent employers from canceling or downgrading existing insurance plans?
Well, there's nothing that would change that. I was the head of Heart and Stroke, so I negotiated private insurance plans. I can tell you that that for insurance companies, they very much want to continue their businesses. So the fact that underinsured and uninsured people are now going to have the ability to get the medicine they need represents no threat to insurance companies. I think that well, but that gets to it. I mean, if you're an employer, as I said, I would negotiate health, the health benefits for employees. That obviously health benefit employees include much more than just diabetes drugs and contraceptives.
I'm
so
asking if
to drop your plan because a portion of medicine it's just not logical, right? No company would do that.
All right. So, if this is a single payer program, is anyone going to lose coverage from existing plans?
The objective here, no. We're making sure that people have choice, so that allows people to have a choice about where they would go. So, for example, if you had somebody with 70% coverage and they can go to a public plan with 100% coverage, I imagine that they would make that choice. But if they prefer their private plan, they could continue to use their plan.
So, you can assure us that no one will lose coverage based on this legislation?
I can assure you, yes.
Thank you. So what consultations did you do specifically with Minister Adriana LaGrange in advance of putting forward this bill?
Yeah, I had conversations with all ministers, including with Adriana, and obviously there's a lot to settle. We just know that we're talking here about diabetes, drugs, and contraceptives, but there's been positive conversations.
She's stated that you did not consult with her before putting forward this bill.
Well, she and I have talked many times.
Did you do it before putting forward this bill on this bill?
Yes, but I mean, I would think that I want to be careful because if I could, Mr. Chair, if I could be precise, because I don't want to mischaracterize it. Obviously, but before the introduction of the bill, those conversations had to be very high level. So in fairness to her, there were not detailed conversations because, of course, I would have been precluded from having those. But we had conversations before and after generally about it, yes.
What about with Everett Henley from the minister in Saskatchewan?
It'd be the same thing. I mean, obviously, before a bill exists, I can't share something of that nature. That would be violating and disrespecting Parliament. But at a very high level, for sure, there were conversations with Everett and in Saskatchewan and elsewhere about the general concept, and that I would come back to him with more details.
Minister Henley is saying that you also didn't have specific conversations with him in advance of this bill. So my question becomes, if you didn't have conversations with the two ministers from Alberta and Saskatchewan, and we know Quebec has shared some concerns regarding provincial jurisdiction. We've had Saskatchewan, Alberta, and Quebec all state that they want to opt out of this program. Why did you not just put your ego down and work with the existing provincial government and their existing plans to provide the coverage for those gaps?
Well, that's precisely what we're going to do. I mean,
That's not what this bill is.
Well,
this is not what this bill does.
Mr. Chair, if I could be afforded the opportunity, there were a lot of people who said we wouldn't get an Aging with Dignity or Working Together agreement with Alberta or Saskatchewan. Of course, we did. And I can say that on this subject, that we've had very productive conversations around the needs in those provinces. I couldn't go into the level of detail of what would be in a bill. That would have violated parliamentary privilege. But afterwards, we've had very constructive.
Do you have a deal with Alberta, Saskatchewan?
We do. We have
Quebec?
deals there are 26 deals across the country. Yes, we have deals with every single province, every single territory on healthcare. They were negotiated collaboratively, and I'm very confident we'll get a deal on pharmacare as well.
On pharmacare, do you have deals with the provinces on pharmacare?
Well, that would violate Parliament. Parliament needs to adopt this legislation before I could do that. So I would be violating. I'd be negotiating with no parliamentary authority. I'm not allowed to do that.
Your committee of experts, will it have representatives from provinces and territories?
So I'm open to your feedback. So, you know, if you
can you
the
commit
committee of
to
experts,
having-
I think is exceptionally important that we have people who understand the current
Okay.
context, and that obviously
So-
provincial consultations with provinces and territories will be
I'm
a
wanting-
critical part of their process.
Minister, I'm wanting to bring forward an amendment to ensure that there is a representative that is named by every single province and territory across the country to make sure that their voices are heard when it comes to the Committee of Experts. Will you allow the Liberal NDP members on this committee to support that amendment? Yes or no?
I don't think consultation any more than federal provincial consultation.
So you won't support that amendment?
No, and I'll tell you why. 'Cause, I mean, that's an extraordinary number of people for an unnecessary outcome. I mean, negotiating
So
with
you
the provinces.
don't think
I talk-
negotiating with provinces is a good idea?
I do that every day. I mean, there's not a province or territory that I'm not speaking to on a daily basis, and that will continue. I've been to every province and every territory at least twice with the provinces, and once in the case of the territories, and I'm talking every day with them. So
I think that is
consultation
exceptionally
is an
condescending to
ongoing
provincial
process.
Thank you,
provinces
Minister.
that have their
Thank
own
you, Ms.
jurisdiction
Goodrich.
on this.
That's your time. Ms. Sidhu, please, for 5 minutes.
Thank you, Chair. Thank you, Minister, and your team for being here with us. The discussion is important, is very, very important, and it's a historical legislation. This aim to increase equitable access to contraceptive and diabetes medication. And Mr. As you know, important progress has been made in our country to fight diabetes. With the national framework, as we discussed Bill C-64, could you update this committee on the progress in implementing the national framework for diabetes as well?
Thank you so much, Madam Sidhu, and I thank you for your advocacy, not only in this bill, but in diabetes generally. And the framework is so important. This is actually part of the framework, right? And one of the things that the framework identified was access to medication. So I would say this is, you know, along with the other actions that we've taken, a really important step forward, along with establishing the Canadian Drug Agency. And frankly, in the chair's home province of PEI, the pilot that we've been running to help folks there, there's been a series of action, and the framework really laid out the path, and this is demonstrative of us being serious about that framework.
Past few years, and this government has put together several national programs to support the needs of vulnerable Canadians, including seniors. Many low-income senior citizens now have adequate dental care access and access to diabetes medication, and pharmacare is going to be transformative. We all know that. How can this initiative combined impact the quality of life, including seniors? It's impacted all Canadians, we know that, but particularly seniors too.
Well, in a very practical sense, I've had an opportunity, and I'll just take dental care because it's you know, I just mentioned yesterday at noon we crossed 100,000 seniors, which in 3 weeks is pretty outstanding. And when you go and you meet with a senior, I think of Raphael yesterday when I was in Toronto, and I had an opportunity to talk with Raphael about what this meant. You know, that he could go in and get that care and that he wasn't going to wind up sick. I think when I was in New Brunswick last week and I was talking to dentists who say, you know what, I know the people who don't have access to dental care, and I know I'm going to see them in an emergency room, and I'm going to have to come in on a Saturday and not get paid and worry about whether or not they're going to lose their life because they didn't have access to care. It's the same thing for diabetes, and what we're making real with dental, we need to make real with diabetes medication and with contraceptives. So it's about getting practical results, and it's about being upstream, which is about not only social justice. As I said, this is a huge, huge opportunity to save money and to avoid strain on our health system.
Thank you. And Mr. Access to the latest technology is essential in managing diabetes. How does this legislation, then other measures proposed by this government, improve access to the technology and devices such as pumps, lancets, and glucose monitoring devices?
Yeah, it's a really great point because when we're talking about medication, we also have to think about the monitoring strips and the pumps and the syringes. As I mentioned, it's tragic, but people are reusing syringes and getting bloodborne diseases for it because they don't have the money for new syringes. To me, that's not the kind of country I think we want to be in. So having a device fund to make sure that people have access to the devices they need is really critical as well, and that's be an important part of the conversation that we have with provinces. On the technology question, that's a bigger answer. But building common indicators, really upgrading our interoperability, focusing on health data, the health data charter that we signed in Charlottetown, and a whole bunch of other actions in health data are absolutely critical to make sure that we have a modern health system.
Thank you. Minister, we know 1 in 4 Canadians with diabetes have reported not following their treatment plan due to the cost. Could you explain how dangerous is for the Canadians living with diabetes who don't have access to the medication, and what is the serious consequences, and then it's costing everything, life sometimes, their life? Can you
Well, sure.
comment?
I can tell you that I was head of Heart and Strokes Ontario mission, and I was head of their national their national program for children and youth. And I can't tell you how many heart disease and stroke patients were as a result of improperly treated diabetes. How many patients in hospitals are winding up there with blindness or amputation or dying because they didn't have the medication that they need and weren't adhering to it. So this is very serious. And I think it's why when we're having this conversation, it's so important to talk about solutions, because I really haven't met, when I'm out there in the country, people who don't want to see us fix this. So I think having a solutions-based conversation is extremely important. We have a really great solution here. I hope Parliament adopts it. I haven't heard another solution.
Thank you, Minister. Thank you, Ms. Sidhu. Suite, M. Blanchet-Jonca, pour 2 minutes et demie.
Mr. Blanchet-Jonca, you have 2 minutes. Thank you very much. Let's just speak the truth here today. For 30 years, Quebec has developed its own expertise to administer its own system without help from the federal government. We didn't wait for the federal government to step in. We didn't want your expertise. You didn't have any. You have a good idea right now, and you have good intentions. Fine. 45% of the Quebec population has access to a pharmacare program already, a public one. 55% of the rest of the Quebecers have access to private insurance. So, Minister, what will the federal government be able to do better that the Quebec government can't do with its 30 years of expertise? Well, allow me to have the opportunity to negotiate with the Quebec government and discuss our common goals so that we can actually be able to increase what's on offer in Quebec already. That is possible, and that is my goal. That's all I want to do. I understand the points that you're making, but the province of Quebec and the Quebec government will be managing their own program, and it's through cooperation that we'll be able to work on this program. So, sure, we want to manage the program, yes, but we want to be able to have the possibility to opt out. Do you know where the best pharmacare program is in the country? It's in Quebec. We have 30 years of expertise. So what more can the government of Canada do with that Quebec can't do? Well, there are many lessons that people have learned from the province of Quebec, and I commend them on what they've done. And I think that through our cooperation, we can actually improve the situation, not only in Quebec, but throughout the country. Well, name one thing that the government can do that Quebec can't do. Well, first, money. Second, we can cooperate. And when you cooperate, all kinds of things are possible. And no one is, those who are concerned about their health are not concerned about jurisdiction. It's my responsibility to work with the provinces to be able to increase the quality of health throughout the country, and including in Quebec. Well, Minister, if you want to improve health in Quebec, then transfer those sums. Transfer those sums. Well, I respect the principle, and we are going to work together. Thank you, Minister.
Ian, please, for 2.5 minutes.
Ça me fait plaisir, Monsieur le Président, parce que
This gives me great pleasure, Chair, because I wanted to say something. there are 9 organizations in Quebec that that made a declaration a few hours ago. There's Solidarité Santé, there's the Association Professionnelle du Québec, the FTQ, a community organization. There are many of these groups that represent more than 2 million Quebecers, and they said this today. They salute Bill C-69, and we have never been closer to a true public universal pharmacare program. This hybrid public-private system in Quebec is a system that needs to be corrected. And the organizations also said that the current pharmacare program is far from guaranteeing fair access to medication, as set out in Quebec's own legislation. They say that Bill C-69 will establish a framework that will lead to a public universal pharmacare program. And they are calling on the federal government to not give in to provinces and territories that are asking for unconditional opt-out with full compensation. So my question to the minister is this: given that this coalition of organizations that represent so many Quebecers are saying that they are in favor of Bill C-64, do you think that it's important for the members from Quebec to listen to these groups who represent so many people in Quebec? Well, yes, absolutely. That makes perfect sense. You know, when you work within a spirit of cooperation, anything is possible. But when you're just looking for fights, well, it's obviously it's easy to find points on which you can disagree. I don't think it's only these organizations, actually, who want this. I think Quebecers want us to be able to work together on improving healthcare. And what you have said is just proof of that. Well, about 15% of the Quebec population is not covered as well under the current system. And when you talk about a private-public system, oftentimes it's more costly. There is profit involved, and it doesn't cover everyone. Mr. Julian, so could you comment on that, please? Very briefly, please. Is that all? Yes, that's all. Thank you.
Dr. Ellis and Mr. Steinley, I think, are going to split the next turn.
That's correct, sir.
Okay, Dr. Ellis, you have the floor.
Thank you very much, Chair. Interestingly enough, in this legislation, it talks about a universal single-payer system. So can you explain that a bit, and not in your usual, ongoing fashion that you like to do, but can you simply explain that to Canadians and what that might mean?
Sure. It means that somebody is going to be able to get the drugs that they need without having to pay.
Okay, great. Interesting. So if somebody has pre-existing coverage, and my colleague talked a bit about this through their employer, this program, why would employers continue to offer their employees a program if this is going to exist?
So employers offer much more coverage than we're contemplating here. This is a very, very tiny sliver of what employers offer. So I can tell you from negotiating these things that there is not the opportunity to go a la carte. And if you try to pull out a tiny fraction, you're not going to save very much. And what you're going to show to your employees is that you're not serious about them. What I've seen from the insurance industry is that they're very anxious to maintain their coverage and their business. And what I've seen from employers is they're anxious to make sure that their employees continue to get coverage.
Again, you just have to go on and on and on. Maybe you could just try answering the question instead of your political grandstanding. So that being said, though, what you've now said is that what you've created is a very basic inferior program on behalf of Canadians. So I find that absolutely interesting. Built into this bill, you talked about the creation of the Canadian Drug Agency, which I understand should have been stood up around May 1st, which is something actually in your purview as the Minister of Health. So I'll give you kudos on that. Given that you could have actually had created an agency which has significant oversight, which maybe you don't realize it should have, because the approvals that are actually done through the process, including Health Canada, PRB, the new CDA, PCPA, et cetera, are the worst, some of the worst at least, maybe not the worst, some of the worst in the country. So you could have actually changed that with this legislation, but you chose not to. Can you tell Canadians why they're going to be left out in the cold waiting for new medications?
Well, they're only going to be left out in the cold waiting for new medications if you're successful in stopping them from getting their medication in the first order. And the second order, Health Canada is known around the world, not only for the rapidity with which we approve applications, but the quality. Canadians should feel very proud, not of me, but of our health officials who every day do extraordinary work to make sure that the products and the medications and the food that they consume is safe. And I think that to cast any shadow on that would not only be not connected to fact.
I think that what I asked you about was the Canadian Drug Agency and why you didn't put some oversight into this bill with respect to the Canadian Drug Agency. It's not my plan to stop Canadians from getting drugs. You're the one who would be responsible for having some oversight of the CDA, which you do not have. And why did you choose not to do that on behalf of Canadians?
I would say that through our existing mechanisms, we have very strong oversight and that we are recognized as being one of the best regulators in the world. And that when people look to approvals done by Health Canada, that they know that that is a gold standard to which other countries look up to. And I'm extremely proud of the people that work in our public service every day to do that.
Medications that were brought forward from 2012 to 2021, the Canadians would only have access to 44% of those. You think that's okay?
I think that we have to be.
Yes or no, Minister? Is that okay or not?
Well, you don't get I don't get to dictate your questions. You don't get to dictate my answers.
Yeah,
and the answer is
a simple yes or no.
Answer
is it okay? Yes or no?
The answer is that when we approve medications, ensuring they're safe and ensuring that people aren't hurt,
is it okay
making sure that they don't injure people's health is a hallmark of Canada's drug approval system that I'm deeply proud of.
And all you choose to do is continue to talk, which is,
well, I don't know. You don't seem to want to let me answer.
You have
interesting.
Point of order.
Mr. Julian on a point of order.
I think the tradition around this table has been when you ask a question, wait for the answer. I would appreciate it if we could get the answer.
Yeah. Dr. Ellis is correct, but there have been violations by both the person posing the question and the person answering the questions throughout this round, quite frankly. There's about a minute left in your turn, Dr. Ellis, if you want to share with Mr. Steinley, or if you plan to.
That's correct, Chair. The rest of the time is for Mr. Steinley. Thank you.
Okay.
Thank you, Mr. Holland. Did the Minister of Saskatchewan ever ask for dental care or pharmacare from your government?
I think they've asked a lot of questions about how we can work together and on dental care, and those questions have been productive. I've expressed to both jurisdictions that if they wanted to operate those programs provincially, as long as they were at the same cost and same quality, that I would be open to that.
I have, from the Minister of Health, we've never asked the feds for dental or pharmacare. So is he not telling me the truth, or are you not telling me the truth?
Well, I don't. You can ask him whether or not he wants dental care or not. I mean, dental care for 9 million Canadians is coming. Well, I can tell you that, and I've had very good conversations with Everett. I have an enormous amount of respect for him. When he and I have sat down and talked, it's about how we can work collaboratively.
And one more quick question
He's never said to me that he doesn't want dental care for people in Saskatchewan. If he said that to you, that's not.
One more quick question. Do you know how much coverage we have in Saskatchewan right now when it comes to diabetes, the diabetes programs in Saskatchewan, and the senior drug program in Saskatchewan, what the coverage is?
Yeah, no, I think, Saskatchewan has done a good job. They have a good program. There's still a lot of gaps, and there's a lot of things we can do together, and Everett and I have talked about those gaps and about how we can improve them to make sure that everybody has care.
Can you tell me what age is covered in Saskatchewan
But I think I would commend Saskatchewan for the work that they've done, and I do agree that Everett has done a good job as a health minister.
Okay. Thank you, Minister. The last round of questions for you this evening will come from Dr. Hanley, please, for 5 minutes.
Thank you, and I'll add my welcome to see you here today, Minister, and thanks to the officials as well for being here. So my first question is along the same lines as some of my colleagues around the table, perhaps a little different flavor, but I think Canadians, and I know people in my jurisdiction, the Yukon, for example, has a large number of public employees covered by insurance plans, as well as some of the larger employers, private employers as well. And so they are very interested, again, in the integrity of those programs continuing, but also in clause 6.1, as has been pointed out, there is this the authorization for the minister to enter into an agreement to make payments to that province or territory to increase any existing public pharmacare coverage and provide universal single-payer first dollar coverage for these specific areas of contraception and diabetes. If we move beyond, is there a vision? Is there a vision ultimately of universal single payer? Single payer is frequently used in the advocacy and various reports recommending that we move towards ultimately a universally accessible pharmacare. Maybe you can tell me about your vision for single payer and how that is compatible with the existing system that many benefit from a third-party coverage.
Well, thank you very much, Mr. Hanley, and I thank you for your advocacy and work in public health prior to this job and during it. So in the first order, what we've said is that this is a bit of a pilot. We get an opportunity to see a single-payer universal system out of sort of an academic construct and be out in the real world. In PEI, we have another model, which is a fill-in-the-gaps model, and we have now a committee that's going to be able to look and examine the costs and the future path for a single-payer universal system. And we're going to be able to compare that and then be able to make informed decisions about the path forward. What I've said is that conversation needs to be informed by data and real-world results and action. And if I could just take a moment to talk about, for example, why contraceptive is such a logical place to start with single-payer universal. You could have somebody in an abusive relationship who their partner has insurance, where they have to go through their partner in order to get the contraception they need. Or you could have a 16-year-old, who wants access to contraception, but doesn't have parents who would support them getting access to that contraception. So this was a very, I think, logical place when you're talking about that experiment, and also because of the number of underinsured folks with diabetes.
Thanks. And on your latter point, you and I actually just had a discussion with one of the family doctors from the Yukon Territory, who is an expert in reproductive health care, also a passionate advocate for access to reproductive health care. And you said in your opening remarks that C47 really provides an opportunity for us to talk more about sexual health and access to sexual health and reproductive health care. So maybe I'll give you a little more space to talk about how important this topic is.
Thank you so much for that. And when I go to AIDS clinics, just as an example, they have a huge problem getting people to come in and get tested and have conversations because of the stigma. And here is something with AIDS that is an entirely manageable condition. It's a chronic condition. It doesn't have to be a death sentence. And so we want people to get care. And in an even more granular basis, how many kids, we look at the teen suicide, where it's around sexual identity issues, where there's shame, and that shame has led to terrible, terrible outcomes. I can say that lack of conversations around sex in my own household were incredibly damaging. When sexual violence was visited upon my family and we didn't talk about sex in our household, that was incredibly damaging and left me very confused about sex. And so having a broader conversation in this country about sex and sexuality and sexual health and sexual autonomy, I think is critically important, and I hope it's part of the conversation that we'll have as we're talking about contraceptives.
Thank you. And if I can quickly squeeze in a third question, you talked about your previous role with Heart and Stroke, and you did some really excellent work there. Heart and Stroke, in their briefing note, pointed out that almost 1 in 10 people in Canada visiting an emergency room due to a worsening health issue is because they are not able to afford their prescription issues. C47, I think, is going to try to help to address this gap. Can you comment very quickly on that?
You're 100% right. And I think if you want, I would encourage every member of committee to go and talk to a nurse or a doctor or, frankly, a dentist about what happens when you don't do prevention right. That it is the most heartbreaking thing in the world to watch somebody you love get sick or die. The only thing that is more heartbreaking is when it was preventable, and it never should have happened. We are too great a country. Our values are, I think, that we shouldn't allow that to happen in this country, that if we can prevent it, we should prevent it. That's what this bill will do. That's what we need to negotiate with the provinces.
Thank you, Minister. We've gone a little bit over the time that you had committed for us. We're grateful to you for showing up right off the hop on this study. And regardless of political views, the passion that you bring to your work is evident. Thank you for that. So, Minister, you're welcome to stay, but you're free to go. We still have about 25 minutes with officials, so I'm not going to suspend because I'm sure we have questions for them. But thanks again, Minister. Colleagues, I know that we're facing an imminent emergency with the lack of coffee. We've made the folks aware of that impending emergency and trust that it will be rectified fairly soon. But we're going to continue on now with rounds of questions, and we're back to the Conservatives for 5 minutes. Dr. Ellis, please.
Thank you very much, Chair. Interesting enough, you know, we had some probing questions with respect to drug approvals in Canada. And as I said previously, the Minister specifically had an opportunity here with respect to this legislation because it does talk about standing up the new Canadian Drug Agency. And there certainly was an opportunity to have some safeguards around the Canadian Drug Agency and drug approvals in Canada. So perhaps now I could ask the officials about the drug approval process in Canada because, quite frankly, we've already established that Canadians don't have access to primary care. I think everybody out there watching knows clearly that it's hard to get a prescription if you don't have access to a physician to write you one, which, again, this government has failed to address, even though they've made it clear historically that they would provide 7,500 new doctors, nurses, and nurse practitioners to Canada, even though we're missing about 30,000 family doctors. So that being said, one of the things that's going to plague Canadians in the not-so-distant future, and is plaguing them now, I spoke about previously, is the number of days from global first launch to public reimbursement. 460 new medicines launched from 2012 to the end of 2021. Now, my colleague from the NDP referenced New Zealand as a beacon. Interestingly enough, in this particular study, New Zealand had the longest time for approval at 1,398 days. And maybe could the officials tell me who had the second longest time for approval of medications amongst this group of countries? Anybody?
I can't tell you that, but I'm happy to speak a little bit more about any questions that you have around the data and the time it takes in Canada for
Excellent.
approvals.
Well, I appreciate that. But Canada is the second worst at 1,301 days for getting new drugs approved in this country. Are you aware, Madame Boudreau, that we are having difficulties getting new drugs approved in this country?
What I can say is that there's a couple of different pathways for drugs to be approved in Canada through our health products and food branch. There is a faster pathway that is about 180 days, and on average, with the ones that do not proceed via that pathway, it's approximately 300 days. We also have an aligned review process between what happens at Health Canada and what happens at CADTH in the health technology to try to speed up access for patients as well.
Sorry, are you disputing the data that I have here? What you're suggesting is that the pathways you're talking about have 300 days of approval? Is that what you said?
Sorry, I'm not disputing it. I think you were speaking about the pathway perhaps as a whole between launch and perhaps patient access or access to a prescription. I was speaking about your latter comment, which is the amount of time it takes for an approval of a new drug submission, for example, by Health Canada.
So you're familiar with that data. You're not familiar with the data that I'm referencing.
No, I'm sorry, I'm not. I could ask my colleague if he is, if you'd like.
No, that's okay. So am I clear then to say that you don't think there's a problem with accessing new medications in Canada for Canadians? It's a long process.
No, I think what I would say is, refer back to my earlier comments that we do have different pathways for Health Canada to approve
Thanks,
the product.
Madam Gaudreau. I mean, I heard that part. Do we or do we not have a problem with the length of time it takes for getting a new drug to be approved in this country?
Well, I referred earlier to the 300 days, and that, in fact, is fairly close to what happens in the U.S. and, in fact, quite close to what happens in the EU.
Yeah, I don't think that's what I asked, though. Do we have a problem or do we not?
Sorry, Mr. Chair, I don't know that I can add anything further to my previous answers.
Okay, fair enough. So on behalf of Canadians, even though there was an opportunity here to change the Canadian Drug Agency and have oversight, the officials and the Minister of Health, in spite of the fact that all Canadians know it takes an excessively long time, as referenced by the data in the study, that you don't think that's a problem. Perhaps that's why we have a problem. The other part that I'll return to is new drug launches in Canada. It appears from the evidence here in front of me that new drugs are not being launched in Canada as frequently in other countries. Do you think that's true?
And you are, I guess, looking at some data that I don't have in front of me, so I can't comment on that. But I would like to come back for a moment and just speak about the Canadian Drug Agency and just clarify for the committee that the legislation does not set out the CDA and does not propose a particular mandate or establish the CDA. It speaks to the types of functions that the CDA will do, and it also speaks to a couple of specific functions. And if you'll permit me just to conclude, the CDA is not being contemplated to be an agency that would review drugs, which is done in Health
absolutely. I totally agree with that. The difficulty is that the Canadian Drug Agency could have been mandated to be have better numbers, and you've chosen not to allow that to happen, or at least the minister has.
Thank you, Dr. Ellis. Dr. Pawlowski, please, for 5 minutes.
So our committee is tasked with reviewing this legislation. We're going to go line by line through it. So with that in mind, I kind of read the legislation, and I have what may seem like some mundane questions. There'll be one provision here which I just don't understand what you mean by this. Perhaps you can explain it to me. And let me start off by saying I've been a long-time doctor. I also have a few law degrees, one in health law. I worked for WHO, actually writing health law, and was part of actually drafting some pharmaceutical legislation. And now I've been in Parliament for 5 years. So if there's anyone who should be able to read things and understand it, I would have thought I would have been one of them. And I don't understand this bit. Principles. So the minister is to consider a bunch of principles when they're consulting with the province and territories with implementing national universal pharmacare. And it says one of those principles is to provide universal coverage of pharmaceutical products across Canada. I don't see within those wording a clear indication of what does that mean. Universal coverage means that every person will receive pharmacare from the government, and pharmaceutical products. Which pharmaceutical products? Like all pharmaceutical products? It would seem to me like a very vague, almost like to the extent that it kind of nullifies having any meaning at all. Like what do you mean? What do you mean by that statement? Or that and it says, and it's a rather weird wording, the minister is to consider. Usually it's shall or will consider, but it's is to consider. But what are they supposed to be considering here? What is the goal of that?
And the section sets out principles, as you've set out, and very much as is stated there, the minister, in moving toward the implementation of national universal pharmacare. You've heard the minister refer to this as being a first phase. You've heard the minister as well refer to the other section of the bill that speaks to contraceptives and diabetes as part of that first phase. What this does is set up the framework generally for the broader discussions that will take place in a step-by-step manner to create the National Universal Pharmacare Program. So universal has the meaning that I think most people would consider it has, which is everyone. So every resident of Canada, everyone who's living here, would have access to a pharmacare program.
Pharmaceutical products isn't defined. So which pharmaceutical products? All pharmaceutical products, or products on an essential drug list? And universal coverage, does that mean that, because we've already talked about this isn't meant to replace when there's an employer who provides pharmaceutical coverage in a pharmaceutical plan, this isn't intended to replace that. But if you say provide universal coverage, it would seem to me to imply that all of us, all of us are going to be provided with a pharmacare program, but that doesn't seem to be the intent. So why put this in? I'm just, again, a little mystified by what's the intent of this section.
If it's helpful, I would refer you to the definition of pharmaceutical product, which is set out in Section 2 of the legislation, and reads as means a prescription drug or related product that is funded in whole or in part through a pharmacare agreement in which the Government of Canada is a party.
Okay, I'm not sure if that helps me a lot, but let me go on to Article 6. It talks about first dollar coverage. I understand perhaps in the industry there's a recognized definition of first dollar coverage. Again, and you would think I'd be someone who'd be familiar with such a term, but I don't know what it is. What is first dollar coverage?
So you're correct that there is, if I can use the phrase, it's a bit of a term of art within the insurance policy business. And so first dollar means that as soon as an insurable event would occur, so in this case, having a prescription filled, the insurance would apply, i.e. the coverage would apply before any other payments. So that, in other words, the person coming to the pharmacy is not paying a copay or something first. It's the insurance coverage that would pay that full charge.
Thank you, Ms. Boudreau. Thank you, Dr. Pawlowski. Suite, Monsieur Blanchette-Jonca, pour 2 minutes.
Mr. Blanchette-Jonca, 2.5 minutes, please. Thank you very much, Mr. Chairman. I want to follow up with Ms. Boudreau. You are the person in charge of strategic policy, so you must usually know what people want. Now, we have a very important statement that was made by unanimous resolution in the National Assembly in 2019 that indicates that the National Assembly reiterates that Quebec wants to have its own pharmacare system, calling on the Quebec government to maintain its own system if it is in place, and call for compensation from the federal government. Did you receive this from your officials? I am not aware of that letter. So this is a unanimous resolution from a parliament. Does this not have democratic value? I'm not sure that I've understood your question. I will repeat it. From a democratic point of view, does a unanimous statement from a parliament, does that not have value? I don't have the expertise to answer that question. You're better positioned than I am. So if the Canadian government, for example, adopted a unanimous resolution, would that have an impact from a democratic point of view? I will just come back, if you will allow me, to what the minister already said. Okay, thank you. You understand the importance of a unanimous resolution and the need to act on it. Ms. Boudreau, I want to follow along with my question. Do you know the Pan-Canadian Drug Alliance? And you understand that it negotiates purchases of drugs to buy them in bulk to get better prices. Is that correct? Yes. So the pharmacare, I'm sorry, your time is up and more. Mr. Julian, you have 2.5 minutes. Thank you very much. I just want to be sure that you got the resolution from unions in Quebec that came out a few hours ago in favor of Bill C-64. If you didn't get it, I can provide it to you. So the CSN and others, and they are in favor of this bill.
Of the approval process around Health Canada, I thought my Conservative colleague kind of cut you off. And I think it's important for members of the committee to understand. It's a 300-day period for approval through Health Canada from the application date to availability to consumers. I just wanted to understand what you were saying.
Sure. I'm just going to ask my colleague to fill in a little bit, but just to be clear, yes, what I was referring to was the period from where Health Canada would review a drug for authorization in Canada and when it would conclude that review. And then what I was trying to refer to as well is there are other processes that take place typically before a product would be available, say, at a pharmacy. That would include a review that we call the Health Technology Assessment by CADTH or INES at Quebec. And then there would be perhaps some negotiation on pricing. But my colleague can fill in on those other steps as well, if the chair permits.
Yeah, certainly. So in terms of the data that Michelle was referring to, it's the Health Canada regulatory standard of 300 calendar days service and meets that over 99% of the time. And as Michelle mentioned, there are expedited routes in there as well. And then to further on the detail of the rest of the drug approval process, there is the Health Technology Assessment Approval process, which I'm going to refer to the Conference Board of Canada's Access and Time to Patient report. So that's the data that I'll be referencing. It's a January 2024 product, and it identifies that the time to review a product following a notice of compliance from Health Canada through the former CADTH is 246 days. That's 2022 data. Average time spent for products that were waiting to be engaged by the PCPA after, and this is CADTH only data, sorry, I don't have for the INS, was 172 days in 2022, and then an average time spent in the PCPA negotiations of 189 days. So there's different sources on what that total time is, and so you've referenced a data point that, as we said, we don't have that one in front of us. We've got 736 to, I've got another data source that suggests 900, but each of those steps is performing a function.
Thank you,
And so to your
Mr.
point,
McDonald.
oh, sorry.
Thank you. Next.
Just a quick follow-up. What was the shortest expedited
No,
approval?
we're well past time, Mr. Julian.
180 days.
Ms. Goodridge, please, for 5 minutes. Yes?
I guess the question is are we going to enforce this? I mean, you told Mr. Julian to stop talking. He still asked the question. He still received an answer. And you know what? I guess if we have rules here, Chair, I would expect that we follow them. If we're not going to follow them, then we'll have utter chaos, which we had with Mr. Julian at the last committee meeting when he chose simply to ignore the rules of the Chair. So I would implore the Chair to enforce those rules, and I would implore my colleague, Mr. Julian, who is want to not follow the rules, to actually follow them and be respectful to the committee.
Point of order, Mr. Chair.
Mr. Julian.
Yes. The last meeting, of course, the chair made a mistake, and I challenged that, which is absolutely appropriate. However, in this case, when an answer is something that all members of the committee want to hear, I think it's the advantage of all members of the committee to actually get that. 180 days.
That's,
180 days.
let's try to get through the last couple of rounds of questions. Mr. Julian's turn is done, and Ms. Goodridge's turn is about to begin. Go ahead, Ms. Goodridge, please.
Thank you, Mr. Chair. So I always find it very interesting to listen to the questions that come from Dr. Pawlowski, and his experience when it comes to medicine is something that I truly do appreciate, and understanding the law background in this is actually further makes it so that I don't feel nearly as stupid, because I also had some of those same exact concerns when it came to reading this bill, and just figured that maybe it was that I didn't necessarily understand it. So my question is, we have a very limited number of definitions in this bill, and yet we are using terms that are relatively new. So why did Health Canada choose not to define first dollar or single payer in this piece of legislation?
So I'll speak first to single payer. It's a term that is used very commonly, and it was used as far back as the 2019 panel report by Dr. Hoskin and that advisory panel. So it's quite a well understood term, and for that reason, there was, in our view, no need to define it. Similarly, for first dollar, as I mentioned, it does have a definition that's quite well understood, and it's not unusual in legislation that if there is a sort of a technical term that's understood within a context, you don't define it, because it has a meaning already.
I appreciate that. So minister is not a defined term that is understood?
That's more of a custom that whoever the minister is that has oversight over legislation, that would typically be set out in the legislation.
Okay, so Indigenous peoples, that's not a defined term?
Again, that's in order to ensure consistent drafting and to respect drafting conventions with other legislation. That's why that term is defined as it is, to be consistent with other legislation throughout the Department of Justice legislation that we have in Canada.
It concerns me, because a piece of legislation should be able to be read as a standalone entity and be understood. And while we have effectively a 4-page pamphlet that is quite light, this is billed by the government as being quite substantive, although we have heard conversation that it's effectively a pilot, so I'm not quite sure what we're actually dealing with here. And so my question is, why the rush? Was it just because of the timeline of the supply and confidence agreement as to why this legislation looks like it was basically pieced together?
No, I can tell you that we worked on the legislation for several months. We work with in fact, probably almost a year. We also work with Department of Justice drafters, with legal drafters, with people that will look at whether the French and the English is consistent. So, in fact, there was a great deal of time spent on developing the legislation.
Was the timeline several months or a year? Because there's a difference between those two.
I'd have to go back and look, to be honest, because it has been a long path for us. But it's certainly been, a number of months, and before leading to the legislation, you do all the policy work as well. So.
And I appreciate all of that. And we have a guillotine motion, effectively, of a programming motion, so we have very limited time. And so not understanding whether this was worked on for several months or a year is actually quite important when we're coming to making these decisions. So I would ask that you submit the exact time that this started being worked on to the committee by tomorrow, so that we can ensure that we have the adequate information as we're drafting amendments and considering the rest of this bill. My next question is, if it was a year, then that was not enough time to adequately consult with provincial health ministers prior to bringing forward this legislation?
The legislation sets up a framework for that consultation. So if you look at the preamble, a couple of things are important. One is that it's very clear on the jurisdictional work and the role of the provinces and territories, so that is set out very clearly in the preamble. And throughout the legislation, in just about every substantive section, there's a clear statement that there will be consultation with provinces and territories. So this is, in essence, the beginning of those consultations.
Within a day of this legislation being put forward, we had Quebec and Alberta both come out very firmly against and saying that they wanted to opt out of this. Is that not terribly concerning that we have two provinces, and Saskatchewan came along not very far thereafter, indicating their concerns with this? Is that not something that concerns you when provinces are responsible for the delivery of health care by and large in this country, provinces and territories, and they are already opting out, and many of these provinces, all of them in fact, already have their own plans, and there could have been work to try and expand their plans, but instead we have a pamphlet of sorts that is a plan to create a plan to possibly create a peace. So the timelines of when this was worked on is extremely important.
Thank you. We're well past time. If you have a brief response, go ahead.
Simply to point out that there is in the legislation a clear commitment to consult with provinces and territories, a recognition of their jurisdiction, a recognition of their role in drug coverage, and this would build and expand on their coverage, as the minister mentioned. It does not replace it. And finally, just to say that there will be a lot of discussion in the context of bilateral agreements, which is also set out in the legislation.
Thank you. The last round of questions for this panel will come from Mr. Johari for 5 minutes, please.
Thank you, Mr. Chair, and thank you to the officials for the hard work you've done on this and for coming here today. Unfortunately, I'm going to follow on the same theme that my colleague, Dr. Pawlowski, has led us down the path. So, in Clause 2 of Bill C-64, pharmacare is defined to mean a program that provides coverage of prescription drugs and related products. So I understand the prescription drug, and related products, however, are not defined, and I think that may leave a lot of room for interpretation. What does related product means in the context of the Bill C-64?
So related products is referred to also in the pharmaceutical product definition, and it is intended, for example, if you look at the contraceptives, you would find that some of the products that are contraceptives are actually medical devices, so intrauterine devices, for example. So that's the idea with the term related products. And similarly, there could be drug coverage where there would be coverage for something like something like the syringes, for example, if that was chosen. And again, that's not a pharmaceutical product, so that's why that term is used.
You talked about the contraceptive. In Clause 6.1 of the bill, refers to specific prescription drugs and related product intended for contraception or the treatment of diabetes. And I think the two examples that you gave, IUD and the syringes, would be an example of a related product. Is there a list of prescription drugs and a list of related product that will be published later on?
The minister referred to the list in his remarks as well. There is a list that was put forward when the bill was first introduced on February 29th. And as the minister noted, this is the starting point of those discussions with provinces and territories. So yes, there is a list available.
Okay, so there's a list and the list is available. Okay, thank you. Back to Clause 4 of the bill that states the minister must, when working with the pharmacare partners to implement national universal pharmacare, consider principles relating to the accessibility, affordability, appropriate use, and universal coverage of pharmaceutical products across Canada. And the minister must also consider the Canada Health Act. Can you explain the similarity that exists between the principle outlined in Clause 4 of the Bill C-64 and the criteria set out in the Canada Health Act?
Sure. There is some similarity around, for example, accessibility and also universality. There are also some differences, though. So, for example, under the Canada Health Act, we speak of portability, which is not a type of term that you would use when you're speaking of drug coverage. So that the principles that are reflected here are more closely aligned with the principles that would be more appropriate in speaking of drug coverage.
So you talked about portability. Can you explain what that is? That's not included in the pharmacare under Bill C-64?
Sure. Portability would be like many of us would experience if we are needing to go to a hospital or seeing a doctor in a different province where we're perhaps visiting family or whatever it may be. It's a bit different with a drug plan, because if you're covered under a drug plan, it tends to be the plan that is reimbursed by that province, so you wouldn't necessarily be able to receive the same coverage in another province. So that's what the term portability refers to.
I got about 40 seconds, which I yield back to the chair. Thank you.
Thank you very much, Mr. Johari, and thank you to our officials for staying on. Thanks for all of the work that you've put into this piece of legislation to date, and for your service to Canadians. We are going to suspend briefly to allow for this panel to take their leave and for the others to get set up and to have coffee, if you wish. The meeting is suspended. back to order and welcome our second panel of witnesses. Thank you all for being here. I know that the circumstances didn't allow you to have that much notice, but you're here and in person, and we greatly appreciate that. So we have with us for the next 90 minutes the Canadian Generic Pharmaceutical Association, represented by Jim Keon, President, and Jody Cox, Vice President, Federal and International Affairs, the Canadian Health Coalition, Stephen Staples, National Director, Policy and Advocacy, and Mike Blesky, Advocate Type 1 Diabetes. From the Canadian Life and Health Insurance Association, Stephen Frank, President and CEO, and the Office of the Parliamentary Budget Officer, Yves Giroux, Parliamentary Budget Officer, and Lisa Barkova, Analyst. Welcome to all of you. We're going to invite you to start off with a 5-minute opening statement in the order in which you appear on the notice of meeting. So we're going to start with the Canadian Generic Pharmaceutical Association for 5 minutes. Welcome to the committee. You have the floor.
L'Association canadienne de médicaments génériques et sa division.
The Canadian Generic Pharmaceutical Association thanks the committee for the opportunity to share our perspectives on Bill C-64 and pharmacare.
And accessible are the key value propositions of generic and biosimilar medicines, which today are used to fill more than 3/4 of all prescriptions in Canada. Expanding the use of generic and biosimilars helps drug plans to fund innovative treatments for patients and contributes to the overall sustainability of drug plans. And, not surprisingly, maximizing the use of these cost-efficient treatments to help fund pharmacare was a key recommendation of the Pharmacare Advisory Council report in 2019. We have provided a brief to members and will focus our remarks today on 3 main areas: the medications to be covered for patients under the proposed pharmacare regime, guiding principles for bilateral agreements, and bulk purchasing, which has not been defined. To the list of drugs, expanding access to ensure all Canadians can benefit from the life-saving and life-altering medicines they need is an important objective. However, the list of diabetes and contraceptive medications in the February 29th pharmacare announcement is not comprehensive. There are important gaps that need to be addressed. We have highlighted these in our brief. The current non-comprehensive approach also raises patient equity concerns, as it could lead to suboptimal prescribing to the medicines that are made available to the public for free and lead to suboptimal health outcomes for patients. We are also concerned that the non-comprehensive approach may provide a disincentive for public drug plan formularies to continue their coverage of a broad range of prescription medicines and provide a disincentive to expand coverage to include new drugs in the future. These same concerns apply to drug plans provided by Canadian employers. We recommend that all diabetes drugs and contraceptives that are currently reimbursed by public drug programs in Canada be covered if pharmacare is implemented. This principle should also apply to medicines added in the future. Guiding principles. Under Bill C-64, the federal government must negotiate and enter into bilateral agreements with individual provinces and territories. An important guiding principle for drug formulary management that is already employed by public drug programs in Canada is to reimburse for only the low-cost alternative product of a pharmaceutical active substance. In order to help ensure the sustainability of the plan, Bill C-64 should be amended to clarify that only generic and biosimilar medicines will be reimbursed once they are authorized for sale by Health Canada and enter the Canadian market. This principle should be included in all bilateral pharmacare agreements. Bulk purchasing. Bulk purchasing is not defined in Bill C-64. It is not clear what this means. It is important to recognize that Canadian governments already combine their purchasing power to negotiate internationally competitive drug prices for Canadians. They do this through the Pan-Canadian Pharmaceutical Alliance, or PCPA. It is critical that the pharmacare regime respects the existing pharmaceutical pricing infrastructure to ensure stability of the Canadian drug supply. This will ensure that Canadians continue to benefit from access to both cost-saving generic and biosimilar medicines and the innovative new medicines Canadians need. Prices for generic medicines are controlled through the PCPA tiered pricing framework. This provides a stable and predictable environment for generic manufacturers to continue to provide existing medicines for Canadians and make the investments to launch new cost-saving drugs. According to PCPA, joint efforts between PCPA and CGPA have resulted in savings of more than $4 billion to participating drug plans over the past 10 years. These savings will continue to grow through a new 3-year agreement between CGPA and PCPA that came into force on October 1st of last year. The PCPA also negotiates prices for biosimilar medicines that are set to be significantly lower than the list price for the original biologic drugs. The expanded use of biosimilars has saved public drug plans hundreds of millions of dollars that have been reinvested into coverage for innovative new therapies and the overall sustainability of drug programs. We recommend that governments continue to exercise their power to collectively negotiate drug prices in Canada through the PCPA. In closing, thank you again for inviting the CGPA and its Biosimilars Canada division to appear as a witness on Bill 364. Jody and I would be pleased to answer any questions you may have. Thank you.
Thank you very much, Mr. Keon. Next, on behalf of the Canadian Health Coalition, Stephen Staples, National Director, I presume will start us off?
Yes.
Okay. Mr. Staples, you have the floor. Welcome to the committee.
Thank you, Mr. Casey. Pleasure to be back here, and dear members of the committee. My name is Steve Staples. I'm the Director of Policy and Advocacy for the Canadian Health Coalition. Founded in 1979, our organization's members work to defend and improve our public health care system. We comprise citizens, frontline healthcare workers unions, community groups, students, and public health care experts. Members of the Canadian Health Coalition welcome the introduction of the Pharmacare Act, Bill C-64. This landmark legislation is an important first step in continuing progress toward a universal national pharmacare program. Canada is the only country in the developed world that has a universal healthcare system that does not include universal coverage for prescription drugs outside of hospitals. Pharmacare is needed urgently to improve the lives of those living in Canada. As we've heard, 1 in 5 people reported to Statistics Canada that they do not have access to prescription drug coverage. Importantly, low-wage workers, immigrants, racialized people are hit the hardest. In addition, the overall cost of drugs to the health system must be reduced. According to the PBO, prices for prescription drugs in Canada are roughly 25% higher than the median for OECD countries. And a single-payer pharmacare system with the power of bulk purchasing is the best route to negotiate lower prices from pharmaceutical manufacturers. Canadian Health Coalition members heartily endorse the recommendations of the 2019 National Advisory Council on the Implementation of National Pharmacare, led by Dr. Eric Hoskins, which was referenced earlier. A nationwide program to achieve public coverage for contraception and diabetes medicine and related equipment, delivered by a single-payer approach through provincial health systems, is a historic step in the direction recommended by Hoskins, his report on Pharmacare. But there are many more steps to achieve universal coverage on the National Formulary of Medicines. We urge the government to ensure the legislation adheres to a single-payer national universal public delivery in partnership with provinces and territories, along with adequate funding and accountability measures in accordance with the principles of the Canada Health Act. And I'd like to share the remainder of my time with my colleague, Mike Beskey.
Through you, Mr. Chair, thank the opportunity to be here. My name is Mike Blesky, and I've been a type 1 diabetic for 19 years. I'm also a gig worker in my 30s. And as such, like many, I don't have private health insurance, and I either cannot qualify or cannot afford to pay for a plan myself. And although Ontario's benefits cover a portion of my personal expenses, my out-of-pocket costs stand at about $450 a month, mostly from my continuous glucose monitor, which is not covered in Ontario, and my pump supplies. That leaves me with hard decisions about the cost of food and rent at the beginning of every single month. It also leads to situations where I'm forced to consider rationing my supplies, which can lead to health complications. My experience talking to nurses, doctors, and other diabetics across Canada tells me that I am far from alone. Insulin is not a luxury for us. It is a basic necessity for every single type 1 diabetic. Without the proper treatment, we are exposed to complications like debilitating nerve pain, amputation, and permanent blindness. A universal single-payer pharmacare system is the only policy that guarantees that every type 1 diabetic in Canada, regardless of their economic circumstance, can access their life-sustaining therapy when they need it. Policies that attempt to fill gaps only leave more gaps that need to be filled later, such as what we have seen in Ontario with OHIP Plus. I'm urging this committee to support this bill promptly so that we can get insulin in diabetic hands as soon as possible. And I'm also asking this committee to ensure that syringes, pen needles, pump cannulas, and continuous glucose monitors are fully covered as part of the Diabetic Supply Fund contained in Bill C-64, as these items represent the biggest expenses to most diabetics and in many cases are not part of public coverage in most provinces. I appreciate your time and we welcome your questions.
Thank you both. Next, the Canadian Life and Health Insurance Association. Mr. Frank, welcome to the committee. You have the floor.
Well, good afternoon. It's a pleasure to be here. My name is Stephen Frank, and I'm pleased to be here today in my role as President and CEO of the Canadian Life and Health Insurance Association. An important part of my job is representing the 27 million Canadians who are covered by workplace and other health benefit plans. Canada's life and health insurers believe all Canadians should be able to access the drugs they've been prescribed. To achieve this, we know that both public and privately funded plans are a necessity. Unfortunately, Bill C-64 falls short of its goal to ensure all Canadians have access to the medications they need. It puts what's working well today at risk. Les régimes de garantie
Workplace benefit plans are an essential pillar of Canada's health system. In the most recent year, life and health insurers paid over 35% of expenditures for prescription drugs in Canada. Our plans cover more drugs than even the most generous public plan. 85% of Canadians have indicated that their health insurance plan allows them to save money, and they don't want any disruptions to it. If they had the choice, they would strongly prefer that the government find ways to provide coverage to those that don't have it.
Who already have drug coverage, I ask members, what will this proposal mean for the average Canadian family? Despite much of the discussion about this bill by various stakeholders, it goes further than contemplating a new pharmacare program for diabetes and contraceptive drugs. It requires the federal government to begin the rollout of a broad pharmacare program for an essential medicines list no later than 12 months after the bill gets royal assent. There are material and many unknown risks to disrupting existing programs for millions of Canadians. The Minister of Health has stated that people who have an existing drug plan are going to continue to enjoy the access they have to their drugs. If that's the Minister's intent, it's not at all clear from this bill. As many of the questions reinforced today, its text is ambiguous. It repeatedly calls for universal, single-payer pharmacare in Canada with no mention of workplace benefit plans. Read in its entirety, the bill could result in practical and even legal barriers to our ability to provide Canadians with the drug benefits that they currently have. For the majority of the Canadians, therefore, this plan, as it's currently written, risks disrupting existing prescription drug coverage paid for by employers, limiting choice, using scarce federal resources to simply replace existing coverage, and leaving a huge gap for uninsured Canadians who rely on other medications beyond diabetic drugs and contraceptives. Now, there is a better way. For example, using the $1.5 billion that has been allocated to this program to target those without coverage would allow the government to provide thousands of medications to several 100,000 Canadians who currently lack drug plans. In other words, we could as a country use scarce federal dollars wisely to make a profound impact on the lives of those who do not have drug plans while protecting the benefits that are currently working so well for the vast majority. So in conclusion, we believe this legislation needs to be significantly amended to focus on ensuring universal drug coverage for all Canadians by addressing any gaps in the drug insurance that currently exists, and to be clear with Canadians about what exactly we're trying to do. I look forward to your questions. Thank you.
And finally, the Parliamentary Budget Officer, Mr. Giroux, welcome to the committee. You have the floor.
Good afternoon, Mr. Chair and members of the committee. We are pleased to be here today to discuss our analysis of Bill C-64, an act respecting pharmacare. With me today, I have Lisa Barkova, our lead analyst on pharmacare. If memory serves, this is the first time that I'm appearing before the House of Commons Standing Committee on Health as a parliamentary budget officer, but this is not the first time that the office has responded to requests from the committee regarding pharmacare. In fact, in response to requests from this committee, in September 2017, my predecessor produced an estimate of the costs to the federal government of implementing a national pharmacare program. Furthermore, following requests from parliamentarians, my office has prepared an updated cost estimate of a single-payer universal drug plan in October 2023. Je vais maintenant poursuivre en français.
I will continue in French. More recently, on May 15, 2024, we published an estimate of the costs of Bill C-64, which you are considering today, in the first phase of a national universal pharmacare program. Bill C-64 is proposing to offer single-payer universal first dollar coverage for various drugs, contraceptives, and diabetes drugs. The program intends to improve and expand and not replace provincial and territorial coverage. We estimate the costs at $1.9 billion over 5 years. The estimate assumes that drugs that are already covered by governments and by private insurers will continue to be so. We will be pleased to answer any questions you have on our analysis on Bill C-64 or any other work that we have carried out.
Thank you, Mr. Giroux, and thank you to all of our witnesses today for being respectful of the time limits. I really hope that that's contagious and that it carries over to the parliamentarians in the room for the rest of the meeting. Dr. Ellis, please, for 6 minutes.
Thanks very much, Chair. I've set a timer. So thanks to all the witnesses for being here. Mr. Keon, maybe through you, Chair, I'll start with you. You talked a bit about bulk purchasing, and when we look at the potential medications that are covered here on this list, can you explain to Canadians, I mean, is it likely this is going to result in significant savings and lowering of prices that currently exist?
Thank you. We do not think it will. We do not think it should. We have negotiated a very broad agreement with the Pan-Canadian Pharmaceutical Alliance that covers public drug plans. It's the same price that private insurers pay, and it is a negotiated price with the provinces, the experts from the provinces, that is intended to provide good savings, good prices to Canadians, and a sustainable revenue base for our industry. So, no, we don't think it will provide savings.
Thank you very much for that, Mr. Keon. And to you, Mr. Frank, you know, there's this concept of universal single-payer plan here in this pharmacare pamphlet. Could you tell us, I mean, the minister and the officials who were here previously couldn't tell us what that meant. They said, well, it's a term that's been used a lot, and you know, everybody knows what it means. You know, you've been at this a while, and obviously I would suggest that maybe you could shed some light on this for the benefit of all Canadians of what that means.
If there's one point to underline today is that this bill is ambiguous, and we actually don't know what it means because it is not a defined term. But you know, the building of this bill, when you read it in its entirety, references to the Canada Health Act, references in the preamble to previous studies that have been done, single payer mentioned multiple times, universal. Those as a package have been well understood in the courts and over time in the provinces to mean, you know, a single payer, not federal, provincial, private, but a single payer. Universal means the same for everybody. And our concern is that that could be interpreted to also mean that private industry is no longer able to provide coverage. So, you know, when you read this legislation, because of that lack of clarity, because those terms aren't defined, we are concerned with the way it's drafted and thinks it needs to be amended at a very minimum to reflect, if the vision of the minister is what the government's intent is, we would be supportive of that, targeting, their efforts on where the need is. But I don't think that we can be confident that that's what the legislation reflects. And so we are quite concerned, and we do believe there's some significant amendments required to reflect what we heard from the minister saying earlier today.
Thanks for that. And through you, Chair, is it fair to say then, Mr. Frank, that our understanding is there's about perhaps 1 or 1.1 million Canadians who lack sufficient coverage. So that could mean that perhaps of the 40 million Canadians, 39 million Canadians that their coverage they currently have could be in jeopardy?
I can only speak to what we cover as a private industry. So there are 27 million Canadians with private drug coverage today in Canada. It's very broad coverage, much broader than even the best public system available across Canada. And they value that coverage greatly. 90% of them value their coverage to a high amount or to a great amount. So they want to protect it, and they are very strongly opposed to having that put at risk. And overwhelmingly, if you ask them what their preferred approach is and you give them a choice, they would like government to target their efforts where the need is. So, we listen to our clients every day. We provide excellent coverage for them. There's 27 million of them that are very happy with what they have, and they don't want to see that put at risk. Everyone would agree people should have access to the medications they need, and so let's target where the problem is, and let's not disrupt what's working well for so many.
Thank you very much for that. And through you, Chair, Monsieur Giroux, thank you for being here. Thank you for your analysis. When we begin to look at federal government spending, we know that the spending is ballooning out of control. That does not mean that pharmacare is not important. That being said, and we've heard, of course, now from Mr. Keon, there's not going to be any savings here. So this will continue to be an expense to the federal government, of course, to taxpayers. Perhaps we don't have that much time, but maybe you could outline that expense that is going to be a recurring expense to taxpayers with respect to Bill C-64.
Yes, in fact, we estimate the cost to be about $1.9 billion over 5 years, which, yeah, billion. So that means about $400 million ongoing and increasing with population increase and inflation over time. So $400 million per year and increasing, roughly speaking.
And sir, finally, through you, Chair, is it not true that this government has added more to the federal government debt than all other governments combined? I think I've heard that said. Is that true in your analysis?
I'd have to look at the precise numbers, but if it's not that, it's not that far off, due to the pandemic, of course, in good part.
Thank you, sir. My time is up, Chair. It's 5 minutes and 18 seconds. Oh, I have 6 minutes. I apologize. Look, I'm so eager to be good. Wow. So eager to be good. Thanks, Chair. So again, what we've heard is this government is adding significant amounts to the debt and the struggles with Canadians having to pay for that, of course. When we look at this again, Mr. Frank, if you could, on behalf of all Canadians, could you help understand what the difference between a private plan and a public plan is at the current time with respect to percentage of medications that might be covered by a private plan?
Typical private plan will cover almost all medications that have notice of compliance. So a typical plan would cover upwards of about 15,000 different drugs. Typical public program would cover less than half of that, and so that's sort of the delta that you tend to see. What you tend to see in the diabetic space in particular, what you will see is that private plans will cover many of the more sort of innovative, cutting-edge things. So things like weekly injections, fast-acting mealtime injections, insulin specific for diabetic comas, things that are not covered on the public plan, we do cover privately. And that's something that I think when we looked at the list that was published with this Pharmacare Act, we were concerned at how narrow it was. I think others have noted that too. So, the vast majority of Canadians have very, very robust plans, covers essentially everything in the market. And we work really hard to make sure that we're doing that in a sustainable way, and we know that they don't want to see that put at risk with any new government programs.
Thank you, Mr. Frank. Next. Yes, indeed. Mr. Naqvi, please, for 6 minutes.
Thank you very much, Chair. I want to thank all the witnesses for coming here today. I really appreciate it. In particular, I want to thank Mr. Blesky for being here and sharing your lived experience. I think that's the most important, at least for me, in terms of all the testimonies I've heard. I was struck by some of the choices you have to make on a regular basis, given your health and the cost of medication. Can you elaborate a little bit more on some of the challenges that you face currently, and talk to us a little bit about what impact this legislation will make in your life if it passes into law?
Sure. In my case, I know that at one point when I had finished a work contract, I did have private insurance. And when it came time to finish that work contract, I was told by that private insurance provider that because of my pre-existing condition, that I was not able to go on to the bridging insurance that would normally be offered to an employee. So therefore, I had to pay significantly more in order to stay on an insurance plan with that company. In another sort of tangential way, I recently started on an insulin pump, so I have been on an insulin pump for about 6 months now. In the months before, I was diabetic, and I'm sure Dr. Pawlowski will be able to agree that these numbers are a little bit terrifying, but my A1C before I started my insulin pump was 11.4. The target for being type 1 diabetic is to be under 7. And since starting the insulin pump, my numbers have now improved to 7.7. So that is a huge increase in my personal health. But I made financial sacrifices to do that because of the fact that I knew that I would be paying out of pocket for a lot of these expenses. So one of the things that I've done in the past in order to try and make my dollar stretch was to take my infusion sets, the cannula that goes into my skin to deliver my insulin, and to try and squeeze an extra 2 days out of that infusion set. What that means is I'm risking scar tissue damage on my stomach. And I've seen folks, friends of mine, that have been on insulin pumps that have been in that same situation where they have pock marks all over their stomach and all over their infusion sets because they've had to ration the delivery supplies that they have access to. So those are the kinds of things that you often hear about. There's also the other knock-on effects. When I was talking to different patients from around the country, I actually was talking to, or I got a letter from a family in Prince George who has a 16-year-old son with diabetes. They have not been able to go on vacation since his diagnosis because they put in upwards of $250 plus a month in order to try and pay for their specific supplies in order to keep him healthy. So we see some significant challenges financially, but also in terms of the knock-on health effects of people that don't have access to these medications. And I think that also stretches over to other areas of medications that aren't even in the current wave of this act. And I think that as we start to expand access to medications, I think we'll start to see those upscale or upstream and downstream costs change significantly over time, which will lead to, personal savings in people's pockets as time goes on.
Thank you. Really appreciate that. Come to Mr. Frank. I think you were present in the room when I asked the minister around the notion around choice and whether this undermines the choice that Canadians would have, or in fact enhances the choice that's available to them. And he was very clear the choice will be maintained, and people have the choice. And this is really clear, creating a floor on two sets of drugs. And there is an important role for private healthcare systems that you are representing. You in your presentation still made the argument. You talked about practical and legal barriers, which I'd like you to elaborate as to what you think are. And are you not satisfied after listening to the minister that choice that Canadians have available right now will not be impacted by this legislation?
I was encouraged by the minister's comments, and I think if we could see that reflected in the legislation, I think we'd be vehemently in accordance with what he has in mind. But we don't see that reflected in this bill. And I think that's the issue that we have. Terms have not been defined. They're used repetitively in different contexts in different ways, and it could be interpreted to mean different things, different sections of the Act. The preamble requires the Minister to take into consideration some previous studies that have firmly recommended a universal single-payer pharmacare program. The Canadian Health Act is referenced throughout. So when you read it in its entirety, it creates an enormous amount of uncertainty. And those terms have developed a meaning over time in Canada through the courts, through the provinces, to mean certain things. And so I think it's, we take comfort in what the minister says, but we also would like to see that better reflected in the legislation. And so when you look at, we talked a bit about dental care today. A lot of care was taken with that program to ensure that it was targeted at those who didn't already have coverage. Protections were put in place to ensure employers didn't drop plans. That kind of care and attention, I think, needs to be brought to this legislation so that it actually, over time, doesn't drift away from the intent that the minister described for us today.
Thank you, Mr. Frank and Mr. Naqvi. Suite, Mr. Blanchette.
We will now go to Mr. Blanchette-Jonca for 6 minutes, please. Thank you, Mr. Chairman, and I want to welcome our witnesses for this hour. My first question is for Mr. Giroux, the PPO. I saw your note on May 15th, 2024, on Bill C-64. You say that this first phase will increase spending by $1.9 billion over 5 years. This would imply that the drugs that are provided by the provinces and territories on private plans would be provided under the same conditions. So does that mean that the $1.9 billion will go in particular to provinces that don't have a pharmacare program, and Quebec and provinces that do have a plan, they will receive less? Well, that does make sense because the plan, as we understand it, and perhaps we don't understand it properly, will complement the plans that already exist and not replace them. So if there is a generous program already in place, then there will be less support. If there is a less generous plan, then more funding will be provided. So if we summarize that, provinces like Quebec, which already has a pharmacare plan, will be penalized because they already have something in place. Is that correct? That could be the case, depending on the negotiations between the federal government and the provinces. But we can't presuppose what the conclusions of those negotiations might be. Well, this is hypothetical, and there are a lot of hypotheses in politics, as you know. So continuing along those lines, so if negotiations don't go well between Quebec and the federal government on the funding transfers, the province of Quebec may get less than other provinces from this. Can we say, therefore, that Quebec is at a disadvantage? We'd have to look at coverage by province to see whether there is subsidization or overspending in any province. But there's no doubt that spending varies a lot from one province to another. For example, for oral contraceptives, there are provinces that reimburse 20 cents per tablet and others 60 cents. So sometimes there's practically no funding. In the current circumstances, what mechanism would you suggest to ensure that Quebecers get what they deserve for their money? Well, I'm not here to make recommendations. However, the provisions in the bill call for the minister to negotiate with the provinces. I think this is more promising. We know that the negotiations will take place, but we don't know what the conclusions of those will be. So thank you. I agree with you there. I also like to have data. Could the parliamentary budget officer give us data on the various provinces and to see what the spending would have to be to make sure that every province is treated equally for this program? If the committee would like us to do that work, we could consider doing so. If we have refined data that allow us to do so, but we could certainly give a good estimate. Thank you for your usual cooperation. I want to talk about the report that you every year on the financial viability for each province. If we look at the 2023 report, 5 provinces, given their GDP, seem to be viable. 5 others aren't, and the territories are not. 50% of the provincial governments, including Quebec, have long-term risks if we have additional public spending. So my question is, again, hypothetical, but based on your analysis, if the government sets up a major program like PharmaCare and decides to reduce its share of the spending, what will that mean for the financial viability for Quebec and the provinces? If the government provides considerable funding to a national program and then progressively reduces its funding or withdraws from it, inevitably that makes it difficult for provinces. They have to decide either to ante up more money or to reduce the offer for the provinces that decide to continue coverage. Thank you, Mr. Giroux. Thank you, Mr. Blanchet-Jonca. Mr. Julian, you have 6 minutes.
Chair, and I mentioned earlier this is a historic moment, historic hearings, and cited a number of important organizations. I did want to shout out to the Canadian Labour Congress, B. Brusk, President. They have submitted a memoir to this committee saying that the Canadian Labour Congress calls for the speedy passage of Bill C-64, an act respecting pharmacare, before the House of Commons and the Senate adjourns for the summer so that millions of Canadians can access contraception and diabetes drug and device coverage, giving them some relief from the high cost of living. And I would note that Elizabeth Kwan from the CLC is here in the room today. And of course, wanted to shout out to the Canadian Health Coalition and thank Mr. Staples for being here. Mr. Staples, we've heard from one party in the House of Commons, the Conservatives, and from a number of lobbyists that the system's working really, really well. What we have in pharmacare now just works well in Canada. You deal with frontline workers, nurses. Is it true that everything is just fine when it comes to access to medication? And my second question to you is the issue of a pharmacare program. Is it true that a pharmacare program will help save healthcare dollars?
Thank you very much. Mr. Julian, I share your concern. When I hear witnesses say the system's working very well, I ask for who is it working very well? We just heard from Mike Blisky. It doesn't sound like the system's working very well for him. So it seems to be working for industry and insurance companies, but it's not working well for all Canadians. So that's why this PharmaCare Act is so important. We must get this Bill C-64 through. And it makes me, again, also hearing that the Canadian Health Act, in the view of industry, creates uncertainty. I would differ. I think the Canada Health Act is very important. For 40 years, it's made a guarantee that Canadians, when they need medical care, they will get it not based on who they work for or what insurance program or how much money they have. They'll get the care because they need it. So I'm very passionate that the CHA creates certainty for Canadians, and we want that system. We don't want a U.S. system. So when I hear frontline workers talk, and they do, and we had 100 frontline healthcare workers come here in February, met with many members of this committee, and I express my gratitude for all of you who took time out to meet, very busy time. These are people that are working with all kinds of issues in their hospitals, in their healthcare environments, but they took time to come to Ottawa to talk about the importance of pharmacare. I mean, that really, with all the challenges that they face in the healthcare system, and you know why? When I hear they say filled prescriptions means empty emergency rooms. They know that if people are getting their medication, if they're not cutting their meds, if they're not making choices today whether to take their medicine or not, they don't end up presenting themselves with far worse conditions in the emergency wards. And that's where a lot of cost savings can come in that we're not hearing about. Of course, there's cost savings for individuals. Of course, there's cost savings for bulk purchasing. We can get those prices down, get them down to the median of OECD countries because they're so high. But also, it saves the healthcare system. St. Michael's Hospital did a study. They took 700 patients who had trouble economically paying for their medication. And these patients went out into the world after they were diagnosed. They mailed free medication to half of them. The other half, they just let them fend for themselves based on whatever that system that we were talking about a minute ago, however that system works out. Well, they found that those people that had free medication provided to them did far better. They recovered faster. And, in fact, they could even put a number on it. It saved $1,600 a year per patient who received free medication. So that's an important factor in looking at how we can save money in a national universal single-payer program.
Thank you very much. I wanted to go on to Mr. Blesky, and I hope you get questions from the Conservatives because you're a real-world person who lives in the situation that exists right now, which is catastrophic for so many Canadians. What would happen if you simply don't have any contracts? You do not have the money for a month. What would happen to you if you're not able to purchase the medication and devices? And I also wanted to ask, where do you buy your diabetes supplies as well?
Well, in my case, I mean, I have very little of a safety net left, so I would mean dipping into my line of credit. You know, that's basically what it comes down to, because once again, I'm part of the Ontario Drug Benefit, so that is basically what is offered to all Ontarians who are low income, and that low income assistance for prescriptions only covers the insulin itself. It doesn't cover all the other aspects. So for those that are taking injections, it doesn't cover syringes. It does not cover needle tips. It does cover a glucometer. But for those that are using an insulin pump like myself, it doesn't cover the CGM, which I needed in order for the pump to work properly. And when it comes to purchasing my supplies, I can give an example here. So I end up buying my stuff directly from the suppliers, and in many ways.
Yes, Dr. Ellis. Yeah.
Yeah, I hate to do this to the witness, but we've already discussed this previously at this committee that there's not going to be any props and doing a show and tell here. I think that's been well established. It may well be helpful, but I think that we need to continue to follow the rules here.
Okay, then I'll do without. So in terms of the individual aspects that I have to order, so CGM, I have to order on a subscription model directly from the company, Dexcom, and that is $200 a month, and then they ship it every 3 months, and that is basically a 3-month contract that I have to renew all the time. When it comes to the individual pump supplies, the company that makes my pump, which is called Tandem, only offers one single supplier, and that is a company called Diabetes Express, which is a subsidiary of Bayshore Health, which is a subsidiary of Shoppers Drug Mart, and they are the only people that I can order those supplies from. So I have to wait for those things to come in from Toronto. In one case, I actually ended up nearly missing a shipment because there was delays in the mail system. If I was able to actually have more access.
Thank you, Mr. Lesky. Yeah, thank you. Next, Dr. Kitchen, please, for 5 minutes.
Thank you, Mr. Chair, and thank you very much, everyone, for being here. Appreciate your presentations. It's interesting that we heard one of our members repeat something that I've sort of hit on a number of times, is basically targeting efforts where the need is supposedly supposed to be. Mr. Frank, you sort of hit that right on nail on the head. You talk about the use of $1.5 billion and putting it to a situation where it may be more effective. Ultimately, when we look at stats that suggest that 1.1 million Canadians don't have any type of plan, and up to 3.8 million are not either aware of a plan that they could have or don't have the funds or choose not to do it. It's a 10% population of Canada, roughly, that doesn't have access to it. But putting that 1.5 billion to that population, I wonder if you would expand on where you think that might be of great value.
Run some simple math on this. It's going to depend on how broad a list of medications you cover, but the typical cost for someone on the ODB program here in Ontario is roughly $1,900 a year. And so if you take that 1.5 billion, if that was an annual thing, you could probably cover most of that gap and provide access on the ODB. So these are just, I think, it's an illustration of the choices that we can make, targeting federal funds where it will make the most impact. Using money to simply replicate what's already in place for 27 million people is, in our view, not the best use of scarce federal resources. And in fact, switching people off of a private plan onto a public risks them actually having weaker coverage than they do today. So I think the vision the minister outlined this morning, we are completely aligned with. I'm not aware of anybody who's suggesting the system can't be improved. I don't think anyone has argued that today. But we should be targeting our efforts where the need is, and not risking disrupting what's working for the large majority of Canadians. As you said, that's sort of 90% of Canadians today.
Thank you for that. And we've heard throughout today, and I think there's been many comments and talked about this legislation not being clear. And it doesn't define things appropriately. I mean, it puts in definitions for a minister, but doesn't put in definition for a first payer. It's very unclear in many ways. And Mr. Keon, you also talked about issues that we're not defining, in particular when we talk about the bulk purchasing. And I'm wondering if there was a way to take a look at that bulk purchasing, would there be any suggestions that you might have to add to that?
Thank you. We would remove the term. We don't like the term. I mentioned that we negotiate our prices with provincial governments. The 3 large federal plans are included in those negotiations. Our prices apply to all Canadians. Public and private reimbursed prescriptions are all at the same price for generic medicines. It is a universal plan. It is a national plan we have. It is negotiated with our industry and the experts who run the drug programs, who know what the drugs do. And it is the most recent one, just came into force in October. We would like to see that continued and respected. And we think that the term bulk purchasing is very unclear, and we're not sure what it means in the bill. So we would like to see it removed.
Thank you for that. I appreciate it. Mr. Giroux, and it's good to have you here. And I recall one of the first meetings that we had when I was chair of the government operations, and the discussions we were having about finances. And in many ways, I felt that you were apologizing for the fact that where we used to use terminologies of millions of dollars, we're now using the terminology billions of dollars. And I think Canadians need to understand that. They really don't understand that we've made that. As I said to you at the time, my wife and I used to talk about nickels and dimes. And now we're talking, instead of millions of dollars, we're talking billions of dollars with this government and the huge amounts of the costs. So when we look at the costs, and in particular, you talked about the 1.9 billion. One of the things that I'm just wondering if you can clarify, especially for someone, because I do have your report here with me, and where you talked about the public drug plans will be 14.8 billion in 2024, increasing to 17.3 billion in 27-28. And I'm just wondering, for people who hear these numbers being thrown all about, they hear numbers and they just question, okay, what are we talking about here when we hear 1.9 billion
Dr.
over
Kitchen,
5 years versus
Dr. Kitchen, you're
numbers
past
like
time.
that?
If you can get to your question, we'll ask for a brief
Okay.
response.
If you could just comment on that, please.
Briefly, please.
Costs that were referred to in our October 2013 report are the aggregate expenditures on public drug plans, and they are expected to increase, and that's the cost for the drugs that would be covered under a national pharmacare program.
Thank you, Mr. Giroux. Dr. Kitchen. Next, Ms. Sidhu, please, for 5 minutes.
Thank you, Mr. Chair. My first question is to the Canadian Health Coalition. I know Mr. Julian touched on that a little bit, but I want to ask that, we know that 1 in 10 Canadians with chronic conditions having ended up into the emergency rooms due to worsening health because they were unable to afford the prescription medications. This is a serious burden on our nurses and doctors and on our healthcare teams in the general. Do you have any number to share with this committee and how this legislation is reducing the burden on the healthcare system?
Thank you very much for the question. You know, there's a term that I've read. It's called cost-related non-adherence, and it means when people are cutting pills, when they're skipping, they're taking their medication that their doctor or care provider has prescribed to them, and they do it because they can't afford it. And you know, it's not even just a simple matter of having insurance, because many insurance programs have copays. And some of these copays can be very big. I live in a community of Regent Park in Toronto. It's a very mixed community. And I was just in my drugstore just the other day when there was a customer in front of me, went out to the counter, and they had to ask what the copay was. And the pharmacist said $14 for whatever it was he was getting. He kind of paused, thought, mumbled to himself, I think I can get that cheaper, and turned and left. And I don't know what happens. And how long does that go on, and do they end up in a hospital somewhere? So we've seen this. I've had nurses tell me they've seen patients who cut their medication and ended up in very serious conditions in the hospital. And as I mentioned, I would refer to this study from St. Michael's that did find $1,600 a year of a savings that can be made by having people having free access to their medication. So that's just a start, and I'm very excited that we can see what this program brings in on these 2 classes of medications. We'll have the expert panel, we'll get a report back, and I think it's going to be very encouraging.
Thank you. My next question is to Mr. Blasky. When you said insulin is not a luxury, it's a necessity. So before that, I was working on Bill C-237. It's a national framework for diabetes. I know untreated diabetes with the serious consequences. So how you feel that, like the person like you, with this legislation, definitely will impact on the life of the quality of that person's life? You want to elaborate on that? What do you think about that?
Absolutely. For me, this has been something that I have been asking for and advocating for since I was in grade 7. One of the very first things I did when I was a type 1 diabetic was attend an all candidates debate in 2006 and ask about, how could I make my life more affordable? and so I know that there are so many different diabetics out there that want to be able to say, I have access to the life-sustaining therapy that I need, because as has been said before, rationing is a huge problem. And it means that people are facing the complications of blindness, of nerve damage, of amputations. And I believe that if every single person with type 1 diabetes had access to the medications that we need in order to survive, the overall burden on the healthcare system will be immensely measurable. But for me personally, I know, like, when I've had those scares when it comes to, you know, like having to talk to an expert about, like, what will my eyesight look like in 10, 20 years, I can be more comfortable with knowing that my eyesight's being protected, that I'm not going to have to face permanent disability. Like, those are the kinds of things that I look forward to when this bill comes into play.
Thank you. My next question is to Mr. Giroux. Your report mentioned behavioral effects on this legislation. Have you considered possible savings to our healthcare system due to increased support for people with chronic conditions that can prevent them from going to emergency room? So it will reduce the healthcare burden, healthcare cost too.
The short answer to your question is no. The mandate of my office is to provide costing and cost estimates. So we rarely do cost-benefit analysis for that very reason, unless we're specifically mandated to do that by a very focused request. But generally, we don't do that.
Thank you.
Thank you, Ms. Sidou. Monsieur Blanchette-Chonka pour 2 minutes et demie.
2.5 minutes. Thank you, Mr. Chairman. I will follow up with Mr. Giroux. I have your analysis on Bill C-64. You indicate that there is uncertainty given the lack of information on all of the things included. So you also talk about the medications, the drugs that aren't in the list. So I have a simple question for you. Do you think that it would be possible that the number of drugs covered might be lower than with this kind of program? Yes, it is possible. The analysis is a technical document. There is a list of drugs that will be covered, and there may be other types of contraceptives, for example, or diabetic drugs that might not be covered. There may be substitutions as well. And what people have been using may not be covered in the same way. Okay? Are there other aspects of your report that you would like to highlight for the committee? No. Maybe my colleague has something? No. Ms. Barkova, I read that you took data from another organization, that is the Canadian Health Information Group, that provided information to you. So I'm trying to understand if we want to have a more clear picture, because this is all kind of theoretical, if we really want to be able to analyze this situation, what extra information do you need from the government so that you could be much more specific?
Comes to mind is having the clear terms and clear requirements for the program, like the specific list of drugs. Like, we know now that it's still to be negotiated, so once we know for sure which drugs are included, it will help us to have a better understanding how to cost such a program and provide a better estimate.
Thank you, Ms. Barkova and Mr. Blanchette-Chonka. Next, Mr. Julian, please, for 2.5 minutes.
Thanks, Mr. Chair. Mr. Bleski, I wanted to come back to you because my question to you in the last round was, what would happen if you couldn't go into your line of credit? You simply don't have contracts. You are unable to take your medication, what does that mean in terms of your own personal health? Because I think that's important to share with the committee, and all members need to understand what the impacts are, the current situation when people can't pay for their medication.
If we're talking about the hypothetical of, actually, cutting into my insulin and like either rationing my insulin or stopping my insulin entirely, by cutting down on my insulin, it means things like becoming blind due to diabetes-related macular problems, diabetic retinopathy. It means neuropathy, which means that it starts with a tingling and a numbness in your legs, which ends up turning into excruciating pain, which also means that there's low blood circulation in your limbs. So that means you're more susceptible to injuries and cuts. And as you don't feel those injuries, they fester, and those complications end up, leading to amputations. Other effects are long-term kidney damage, long-term liver damage, because all that sugar in your system has to be flushed somehow. So your kidneys and your liver end up working overtime in order to get that glucose out of your system.
Is that reversible?
No. Pretty much any change that as a result of high blood sugar, like there are acute symptoms and then there are the long-term symptoms, and the long-term symptoms are completely irreversible, which eventually they lead to fatalities, especially when it comes to ketoacidosis, which is the most acute form of high blood sugars, and that oftentimes comes in very, very quickly as soon as a diabetic loses access to their insulin. So
how long?
If I had to stop taking insulin, I would probably be in the hospital within a day or less. It can be that fast.
Thank you. I can't understand why anyone would oppose this legislation.
Yeah. Thank you, Mr. Julian. Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses. So I have a series of questions, but I guess I'm going to start out with to you, Mr. Frank. Workplace benefit plans. So if a workplace decides that they want to add a particular drug or service, is there a possibility to add just one service?
Well, yes. I mean, if you mean by service, so a typical plan would cover prescription drugs, would have dental coverage, vision coverage, would have all the paramedical services, travel. So there's a suite of solutions that can be provided there, and employers can have some flexibility into what they want to offer. At the end of the day, it's their choice what package they want to offer to their employees rather. With respect to the drug class, yes, we absolutely do see employers covering certain classes of drugs and not others. You tend to see that in the higher cost areas. Some of the rare disease spaces, for example, certain medications would be considered on and off, and different employers will have a different tolerance for how much risk and cost they're prepared to sustain. So we do have a variability in what's offered to Canadians. And
based on that, if this bill were to go forward, would you be concerned that employers would come to you asking to have these two classes of drugs removed from their current plans, therefore driving up the cost to taxpayers?
that is a concern, and I think, again, if you read the legislation, it doesn't stop at those two drugs, and I think that's one of the big things we need to keep reminding ourselves. It contemplates within a year going well beyond that. And so if you get into a situation where hundreds or thousands of medications are covered, then absolutely employers are going to start asking themselves, you know, why should I be still in the game? And so we work really hard to educate them on the value of the programs that they're offering their employees. They, like I said, tends to be more flexible, much broader than what they may get on a public plan. But that pressure and those questions will start if this bill, you know, 2 years down the road has come to fruition. And so I think, and again, that's not the vision that we heard from the minister today. So I think that disconnect is what's giving us pause.
No, and I appreciate that, and I really do appreciate, Mr. Blesky, you sharing your lived experience when it comes to your experience with the OHIP plan or OHIP Plus. As someone from Alberta, I'm not terribly familiar with Ontario's plan, so I did find that to be quite insightful. I'm frustrated in large part as we're studying this bill, that we don't have the opportunity to hear from all different provincial plans to see where those gaps particularly are, because I don't necessarily know if those gaps are the same in every single province. And so my question becomes, are we creating, potentially by going down this path, are we solving for a problem that might not exist equally across the provinces, and therefore creating a situation where we are going to reward provinces that have done very little and perhaps not provide that, which would therefore ask the question of, would provinces continue to offer these kinds of plans if they were to not do this? So this becomes this very circular question of creation and complications. So my question to Mr. Giroux, when you have put forward your prescription costings in your most recent budget, did you factor in the record-breaking inflation we're facing in the future costings?
Yes, we took into account inflation, past inflation, as well as our projections for future inflation.
So did you also factor in if provinces were to drop some of these drugs from their existing plans?
No, we did not include any potential provinces reducing coverage for diabetes and contraceptives.
So this could potentially cost substantially more if provinces and territorial plans decided to remove these drugs as a result of this legislation.
It is indeed a risk, as would some some employers, who could decide to reduce their coverage, knowing that there is a public plan that would cover their employees.
So effectively, we have very little idea how much just these two drug categories will effectively cost the federal government. So we're being asked to vote on something that we have no clue how much it's going to cost.
Well, I wouldn't say we have no clue, but there's quite a bit of uncertainty regarding the costing of such a plan. Public plans and private plans to offload some of their responsibilities onto the public plan.
I find that very concerning, and I want to thank all of you guys for being here today. Thank you.
Thank you, Ms. Goodrich. Dr. Hanley, please, for 5 minutes.
Yeah, thank you very much, all of you, for being here and for the interesting testimony. Just briefly, maybe to follow up, Monsieur Giroux, on some of your answers. I note there's no territorial analysis. Is there a reason obtaining data? Is it about small numbers, or can you just clarify why territories are not included in the analysis?
It just simply comes down to the fact that the data that we use for this analysis contains only provincial data. Had we had territorial data, of course, we would like to include that in our analysis.
Yeah, would love to see that included in future analysis. Thank you. And can you comment towards the end? And forgive me for not really perhaps understanding as well as I should, but maybe I'm representing Canadians to some extent as well. But economy-wide savings. So you say drug expenditures in Canada would be reduced by having a single payer due to a few factors, including increasing negotiating power. So could you just comment on give me a bit more explanation on what you mean by economy-wide savings?
Sure, and you're probably referring to our October 2023 report, where we costed a Canada-wide single-payer universal plan that would cover most drugs. So in that case, we assume that the bargaining power of the federal government would allow the single-payer, well, I say federal government, it could be individual provinces, but let's not get lost in these details. So a single payer would have a negotiating power and could presumably also be able to negotiate additional rebates. And that's where the economies would come from. And they would probably more than offset the coverage of those who don't have any coverage right now. So that's why we say there would be overall economies if you look at the cost of drugs as a whole, as a big bubble.
Okay, thank you. That's very helpful. Mr. Staples, if I can turn to you, and I wonder if you can comment. You've been very helpful in your passionate testimony, but either when you're talking about system-wide or individuals that you've been hearing from. But when when Mr. Frank talks about why don't we put the money into just targeting where the need is and kind of leave the rest alone, what are your thoughts on that?
Thank you. I mean, I hear you. We want to make effective use of public dollars. We want it to get to places where it is needed most. But the aims of the program, of the legislation, is not just to provide medication to Canadians, but is also to get the price of drugs lower. We've got to get the price down. So it's no surprise to hear criticism of bulk purchasing from, in the discussion today from certain quarters who don't want that. But I think Canadians do. Our healthcare system does. Right now, we spend as much on drugs in our healthcare system as we do on doctors. And in fact, only hospitals is the next higher up. So we've got to get the price overall of drugs down to a lower level. That's going to require a coordinated bulk buying strategy. Some provinces, not all provinces, pay the same amount for pharmaceuticals. There's different arrangements that are made. And as Mr. Giroux mentioned in his very interesting October 2023 report, said that increased transparency from a bulk buying strategy will help lower the costs to everybody, because all provinces will get the same price as opposed to one.
I'm going to cut in because I just want to hear from Mr. Blesky before my time is up. Mr. Blesky, you may have noted that the Yukon Territory was the first jurisdiction in 2020 to cover CGM. And I wonder what you think of, I mean, now other provinces have come on board with that, but when you look at the sort of the piecemeal approach versus a coordinated national approach, like how do you feel about how we can do better with a coordinated national approach, incorporating C-47 into this?
Yeah, I think that a coordinated national approach is really important because as we're starting to see, the international research consensus shows that CGM usage is tied very successfully to better health outcomes, and I think that the research in Canada shows the same thing. So when it comes to the federal government coming in and being a partner in supplying CGM technology to Canadians, I think it's a very strong step forward. Especially given, not only is it effective for type 1 diabetes, but it's also very effective in monitoring blood glucose levels in type 2. And in fact, there are companies that are coming out with new CGM technologies that are specifically designed for type 2 diabetes, for prediabetes, and those with pregnancy that are monitoring their blood glucose levels.
Thank you. Thank you, Mr. Blesky. And next, Dr. Ellis, please, for 5 minutes.
Thanks very much, Chair. And again, thank you to the witnesses being here. Mr. Keon, I think we've heard some testimony that perhaps you could clarify or a question from Mr. Staples that medication costs might differ across the country. Could you tell us, is that true? And are there jurisdictions that have prices that are better than others in Canada?
Thank you for the question. Yeah, I should clarify. I'm here today representing the off-patent industry, the generic and biosimilar industry. We fill 75% of prescriptions for about 20% of the costs. So there's 80% of the costs that don't go through the companies that we represent here today. But as I've said twice already, we have a national system on pricing. Quebec participated in the latest round of negotiations for the first time. It is a national system. All provinces pay the same price. All payers in Canada pay the same price for generic medicines. And so when I say that we don't like bulk buying, I think we already have a national system that's negotiated with experts who run drug programs, leads to low prices. And that's what we want. We are concerned with terms like bulk buying. If it implies that there's going to be some attempt to drive pricing down lower, countries like New Zealand bulk buy. When we look at the data, they have fewer drugs available than elsewhere. And so that's not a system that we recommend. We have worked very hard with the PCPA, with the provinces, and the 3 federal drug plans to get a system. And we think that system should be respected.
Thank you very much for that. And through you, Chair, to the Parliamentary Budget Officer, one of the things that does concern me is the loss of coverage on behalf of all Canadians. And if you do some napkin-based math, perhaps this program was based on 1 million people. If 40 million people are, going to have to enter into this program, I mean, I can do the math in my head, but I'd like to perhaps hear you say it out loud with your credibility as the PBO. What would be the cost for simply these 2 classes of medications on the basis of 40 million Canadians?
That, unfortunately, I don't know off the top of my head. If all the
40 times the amount, would it not? I mean, is that not the math?
Lisa tells me that we have the numbers, so I'll probably let her speak. Sorry.
If you look at the table that we provide in our costing note, the very first line, the cost will amount to approximately 5.7 billion, would give you an estimation for these same drugs, if the program covered everyone in Canada, how much that would cost. And then you can see the cost recovery due to public plans or the private drug coverage. That's pretty much the cost recovery, what currently public and private plans cover.
Right, very good. But this, again, I don't have that table, or I can't find it right in front of me. But that being said, are you suggesting that public plans would continue to cover these medications because they're funded by provinces in that estimate, or are we suggesting that this is for all Canadians?
Well, the numbers that Lisa mentioned is the expenditures that are currently being covered by public, private, and out-of-pocket expenditures. So for the drugs under C64, contraceptives and diabetes, about $5.7 billion. So that's assuming that all these expenditures would be covered by the federal government. That's how much it would cost. And then we don't make any assumptions as to whether provinces would continue. Well, we assume they would continue because there's no sign that they will withdraw, but if they were to withdraw their coverage, then the federal price would go up, obviously.
Right. Great. Thanks for that. When we begin to look at this, I mean, this is a small fraction of medications out there. Certainly, that's not to say that the medications for diabetes and contraception are not important. Certainly, they are. As a former family doctor, I wrote lots of prescriptions for both of those medications. Maybe, and I know you don't have a crystal ball, Monsieur Giroux, but, when we look at the costs of other medications that are currently coming down the pipeline, they're significantly more, often thousands or hundreds of thousands of dollars. And what might that look like? To me, that's a catastrophic number. 5.7 billion multiplied by hundreds of thousands. Is that a fair estimate?
Everybody needs these expensive drugs, fortunately, but it's true that generic drugs tend to be a relatively small portion of all prescriptions, but a much higher proportion of total expenditures. So you're right, when new drugs come onto market, they tend to be much more expensive than generic drugs, as I'm sure Mr. Keon will attest. So there's a potential for new drugs to push expenditures on drugs upwards.
Thank you, Mr. Giroux and Dr. Ellis. Next, Dr. Pawlowski, please, for 5 minutes.
There's private and public drug plans, right? And if you look at private plans like Blue Cross, Canada Life, Manual Life, they're all for-profit, run by for-profit companies. Is that right? Are any of them not-for-profit in the private sector?
Well, thank you for that question. That's a common misunderstanding. In fact, the majority of the companies operating in this space are not-for-profit. So Medavie would be a not-for-profit company. Green Shield, the Blue Crosses, Beneva. So they
Which
are not.
which ones are not for
Well,
profit?
all of the Blue Crosses across the country, Beneva, a large player in Quebec, Green Shield, all of them are not-for-profit. So if you look at the number of carriers in the country, probably about over half are actually not-for-profits. They reinvest everything they make back into their communities. And then there are certainly large players who are for-profit as well. So it's a mix.
Do you know of employer plans, what percentage are non-for-profit and which percentage are for-profit?
Yeah, I don't have that number in front of me. I apologize.
So why would an employer not right away get a non-for-profit insurer?
You know, the for-profit companies provide a very compelling solution to clients, and so do the not-for-profits. It's a very competitive market. There's over 20 insurers that compete for business, and employers will make decisions based on what's best for them.
You think non-for-profit or for-profit insurers can provide the same sort of plan at the same cost as a non-for-profit one? Are they that competitive that you say, okay, because I would have thought like the concern with any private insurer in a private company that's a for-profit company then isn't a percentage of the employees what would otherwise be their benefits, their income, instead going to the profit of the corporation. And so, like, why would anyone, unless they can be that efficient that they actually provide the service cheaper than a non-for-profit, why would anyone have a for-profit insurer?
You know, that's a case by case. You'd have to look at the situation of each employer and what they're looking for in their benefit plan. But it is a very competitive space. Many of these, the majority are not-for-profits, as I mentioned. And I think you can infer that the profit that's being made in this space is quite low, even for the for-profit companies. So it's important, very important. We offer incredible value to Canadians. We're very proud of that. And as an industry, we compete really hard to make sure we're doing the best that we can for them and ensuring that they have the ability to access what they're entitled to.
Can I assume that for-profit companies would argue that they provide a broader set, better coverage than the non-for-profit ones?
I don't think you could make that general statement, no. I think it's an extremely competitive space. Everyone's competing with a very broad suite, and employers make decisions based on what's in their best interest. So it's a case by case, hundreds of thousands of employers out there who have different reasons for going with different providers.
So an employer has to basically buy a plan for their employees, right? And in the case of for-profits, what percentage of the money that goes towards that plan ends up in profits? You've said it's small.
It's very small. Again, I don't have that detail in front of me, but what I can say is that it's a mixed system, for-profits and profits competing aggressively. The thing that unites them is that we provide coverage for 27 million Canadians. All of them get much better coverage than they would on any public program. And we're very proud of the service that we offer to Canadians. And we also know that overwhelmingly, they don't want that disrupted.
I'm going to sound like someone in Peter Julian's party here when I say this, but why would you enter? Why you as a company, as an insurer, would want to enter the business if your margins are so small? I mean, why form such a company? I mean, I'm being a bit skeptical of the fact that you're saying, oh well, you know, they hardly make any money at all. Well, I don't think many companies have that kind of mindset as when you're a corporate executive with those companies.
Well, it's a business that's important to us. It's a very competitive business. Margins are low. And we're competing every day to offer the best service that we can for Canadians. And I'll just reiterate, the 27 million Canadians who have those coverages today do not want to lose it. And so I think as the government contemplates its go-forward plan with pharmacare, what the minister was talking about today makes a lot of sense. That's not what's reflected in this legislation. And so I do think amendments need to make sure that that maps to what we heard this morning from the minister. And I think we would work very closely with the government to try and target the solutions to those who need it and to leave what working well in place today.
Thank you, Mr. Frank. Monsieur Blanchette-Chonka pour 2 minutes et demie.
2.5 minutes. Yes, I would like to follow up on my questions with Mr. Frank. In Quebec, the pharmacare plan has been in place for 30 years, and we hope that others in Canada will follow suit if they find it a good model. There is an amount that people pay, a user fee, but I would like to know, there is a deductible. So if we eliminate the deductible and have the first dollar payment, how can that really work? What I can say is that we think that Quebec's system works quite well, and it could be a model for other jurisdictions in Canada. We agree with you. The public and private sectors work together to provide exceptional coverage for Quebecers. I can't speculate on how it could work within this bill. It isn't clear. As I mentioned, the terms aren't clear, but one of the big risks in this legislation is that people can come to different conclusions when they read it. I think that it needs to be reviewed and amended so that it is clearer. The system in Quebec does work very well, and thank you for recognizing Quebec's expertise. You work in this field. What area of Canada has the best plan? Every area is different, but I can say that Quebec has a very good system. It has a partnership between the public and private sectors and provides universal coverage for all Quebecers. It's a very good system. Could you also give us the opinion on who is going to be deciding on these drugs? Is it going to be the Canadian Drug Agency or INES? We know how it works with INES in Quebec, and we would have the Canadian Drug Agency elsewhere. We don't recommend any changes. It seems to be working well. INES works very closely with the federal government on this, so it works. It is a question, though, about as to who will decide what is covered, and the coverage changes, how frequently they will take place, and so on. Thank you.
Round of questions for this panel will come from Mr. Julian for 2.5 minutes.
Merci beaucoup, Monsieur le Président. Mais là, il faut...
Thank you, Mr. Chairman. We will have to repeat this because some people in Quebec may not be aware. There is a coalition representing 2 million Quebecers. We have the health professionals, the community and volunteer, the CST, the CNSN, big unions. In their brief, these organizations have indicated again that the Quebec Pharmacare Plan does not provide fair and universal coverage. The various costs to people that they have to pay when they get drugs are problematic. They are a sort of user fee, and so people ration their medication as a result. Given that the Quebec private-public system doesn't work according to over 2 million Quebecers, what is the conclusion when we have people saying, oh, everything is fine, and we should stick with what we have instead of having a federal plan?
I think that fine for who is what we've got to talk about. Is it fine for Canadians? Clearly, we hear people in Quebec are not happy with the system that they've got. If you talk to one of the leading health economists, Steve Morgan from the University of British Columbia, he's run the numbers. He says that Quebec is paying for drug medication as one of the highest jurisdictions in the world. In fact, per capita, they're only topped by the United States. They pay more than Switzerland. So, and in fact, if that system in Quebec were translated to other provinces, costs would actually increase because of the problems in the system. And so I think that I take the word from experts, from economists, health economists, to say that look at the Quebec model very closely, listen to what people are saying. Is that the system that we want to have for the rest of the country? Or do we want to go with the kind of single-payer national universal system that's envisioned in Bill C-64?
Thank you, Mr. Julian. Thank you, Mr. Staples. And thank you to all of our witnesses for being with us today. Certainly a great variety and diversity of expertise, all of which is valued and appreciated. Thank you so much for being with us. We're going to suspend until 7 o'clock to allow for this panel to take their leave and to get the next panel installed. The meeting is suspended. like to welcome our final panel of witnesses for this evening. Under the programming motion that is guiding us through these proceedings, we are not to sit past 8:30, and I'd like to wrap up a little bit before 8:30 so that we can pass the budget, just to give you an idea of the timeline. A big welcome to the witnesses who have joined us here this evening. We have from the Canadian Pharmacists Association, Joelle Walker, Vice President, Public and Professional Affairs. From Heart and Stroke Foundation of Canada, Manuel Arango, Vice President, Policy and Advocacy. Sorry if I butchered your name. National Indigenous Diabetes Association, Inc., Celeste Thériault, Executive Director, and from the Society of Obstetricians and Gynecologists of Canada, Dr. Diane Francoeur, the Chief Executive Officer. You're probably aware that opening statements are 5 minutes in the order listed on the notice of meeting, so we're going to begin with opening statements now, starting with the Canadian Pharmacists Association. Ms. Walker, welcome to the committee. You have the floor.
Monsieur le Président. Mr. Chairman, ladies and gentlemen, members of the committee, thank you. We're very pleased to have this opportunity to share our views with you tonight on Bill C-64. I'll be giving my remarks in English, but I'll be pleased to answer your question in French or English.
Tonight is really aimed at providing the committee with a very practical perspective on what could happen at the pharmacy counter as changes are contemplated and considered as part of the legislation. And my testimony will focus on 3 points and 3 points only. The first is really around the role of pharmacists in pharmacare. As anyone who's used a prescription drug will know, pharmacists are the last person that the patient will see before they get their medications. And while the act of dispensing is complex, pharmacists do a lot more than simply fill and sell medications. They provide critical care and counseling that are integral to the effective use of medications. Their daily interactions with patients place them in a unique position to understand their needs, educate them on proper medication use, and advise on potential drug interactions. And pharmacare really should be about more than just the cost of the drugs, but rather the care that goes along with them. Pharmacists also play a significant role in drug plan management and navigation, and that's not often seen by many patients. Every day they submit millions of claims on behalf of their patients. They spend time on the phone with insurance plans, and they help patients identify alternative treatment options that are covered by their plans. It's for this reason that it's essential that we have a pharmacist on the government's proposed committee of experts. The second point I'd like to make is around the best target to target medication coverage. Contraceptive and diabetes medication are two very important drug classes, and there's no doubt about that. There's also no doubt that there's too many people in Canada that don't have access to these drugs for cost-related reasons. However, the focus of Bill C-64, which aims to provide free contraception and diabetes medications to all Canadians, irrespective of their existing coverage, could warrant reconsideration. The intent of reducing the burden of these drugs is the right one, but our view is that the projected cost of over $1 billion could provide even more comprehensive coverage if directed towards expanding coverage for a broader range of medications for those who currently lack adequate coverage, rather than replacing coverage for those with existing drug plans. We believe that such an approach would be more feasible, fit better with the needs of provinces, and limit disruptions, all while ensuring universal coverage for all. And that brings me to my third and last point. While change is sorely needed to ensure universal pharmacare, the potential for significant disruption can't be overstated. And as members of this committee can likely attest from the recent PSHCP or Public Service Healthcare Plan changes, changing drug plans can be very disruptive for plan members and for pharmacists. Switching patients from a private drug plan to a public drug plan can be equally disruptive, so changes must be implemented carefully to avoid confusion and reduce administrative burden. The reality is public drug plans across Canada are far less comprehensive than private plans, which means that if the legislation shifts patients from their private plans to their public plans, pharmacists and physicians will likely have to spend a considerable amount of time switching patients to new therapies, especially if their drug is no longer covered under a public plan. filling out paperwork to get special exemptions, and communicating these changes with patients. And if I can, I'd like to provide maybe a personal example in conclusion. I'm on a birth control pill that is not on the current list that's been proposed by the federal government, and it took me 3 years to find the pill that worked for me and that didn't have side effects that I, lived with daily as a woman. This raised some very real questions for me when I looked at the intent of the bill. Will my employer continue to cover contraceptives if that's not covered? I'll certainly lobby for it, but it's definitely a question in my mind. Will my pharmacy continue to stock products that aren't broadly covered? And if there are exemptions, will my pharmacist have to apply for that exemption on my behalf, as they often do with many drug plans? So I hope this was able to give you a sense of frontline issues that could arise, and I thank you and welcome your questions. Merci.
Thank you, Ms. Walker. Next, representing the Heart and Stroke Foundation of Canada, Mr. Arango.
Thank you very much. Heart and Stroke applauds the Government of Canada and Parliament for introducing Bill 64, which will lay the groundwork for equal access for life-saving drugs for all. People in Canada appreciate our universal health care system, but the reality is Canada is the only country with Medicare that does not include prescription drugs as part of its universal health care program. The current patchwork of public-private plans in Canada has created fragmented drug access, leaving millions struggling to afford their prescription medications. I don't think there's any disagreement with this. While many people in Canada have some sort of form of drug coverage, it is often insufficient and poses affordability issues. So the 2019 Hoskins report indicated very clearly that 7.5 million people in Canada had either no coverage or insufficient drug coverage. As well, the 2021 survey on access to healthcare and pharmaceuticals during the pandemic found once again that 1 in 5 people did not have insurance to cover any of the cost of their prescription medications in the previous year. Furthermore, a poll commissioned by Heart and Stroke and the Canadian Cancer Society in 2024 found that 1 in 5 people in Canada do not have sufficient drug coverage. 1 in 4 had difficulty and had to make difficult choices to afford prescription drugs, such as cutting back on groceries, delaying paying rent, mortgage, or utility bills, and incurring debt. Furthermore, the same poll found that 1 in 10 in Canada diagnosed with a chronic health condition were more likely to visit the ER due to a worsening health issue because they were not able to afford their prescription medications. A study in 2016 also found that 16% of people in Canada went without medication for heart disease, cholesterol, and high blood pressure because of cost. With the introduction of this bill, the foundation is being laid for the first phase of national universal pharmacare through single purchaser coverage of diabetes and contraceptive medications, ultimately providing equal drug coverage for all people in Canada, regardless of their gender, race, geography, age, or ability to pay. But we do feel that this needs to be expanded in the future to cover drugs such as heart disease and stroke. The reality is that millions of people in Canada live with heart disease and rely on daily prescription medicines to help keep them alive and to manage their condition at home. In fact, in 2022, 105 million prescriptions were dispensed for cardiovascular diseases, making it the second highest disease category. Universal coverage of essential medicines will reduce pressure on the health system by cutting costs. Because treating a condition such as high blood pressure, which is a leading risk factor for stroke, is more cost-effective for our healthcare system than the specialized care required to save a life after a stroke. Heart and Stroke has made a number of recommendations for amendments in our submission, but I'd just like to highlight one today, and it pertains to Section 8, parentheses 1, regarding a national formulary. And we recommend that there should be a definition inserted here for essential medicines. In particular, essential prescription drugs should initially be defined as those included in the Clean Meds trial. That's one way to define essential medicines. We feel that the government must take quick action to close the gap in coverage that leaves out essential medicines for chronic diseases, including heart disease and stroke, that affect many in Canada. We also recommend that the minister prioritize the signing of bilateral agreements with provinces, territories, in tandem with the progression of the bill, and to pass this bill before the House adjourns for the summer. Finally, I would like to address some other key points and misinformation about pharmacare. The reality is that the federal government, as a single drug purchaser, would be able to negotiate much lower prices compared to the myriad of private and public plans. And this would have a significant deflationary impact on the average drug price. So we heard comments earlier on about bulk purchasing, and it's a very well-known business in the world of business procurement, that a company that buys 100,000 widgets from a manufacturer is going to get a much better price per widget than a company that buys 5 widgets per year from the manufacturer. So the reality of bulk purchasing and the fact that it leads to lower prices, it's well known throughout the world. In New Zealand and Australia with respect to drug purchasing. And even just in general, if you look at Costco, bulk purchasing there leads to lower prices. So a national pharmacare program will not, another point too as well is the notion that coverage is going to be decreased through pharmacare, a national pharmacare program. And in fact, it's going to be the opposite. We're going to get enhanced coverage. The reality is that we have 7.5 million people that don't have coverage or inadequate coverage. The objective is to increase coverage for those people. So it's just not reality that we're going to get reduced coverage. If the government, the federal payer, is covering a diabetes generic drug, if that's in the private plan or in the public plan or in the federal plan, it doesn't matter. One way or another, it's going to get covered through one of those 3 ways. So I don't foresee reduction in potential coverage. It's the opposite. We're aiming for the opposite. So to conclude, Heart and Stroke applauds the federal government and Parliament for the introduction of this legislation, proposing an affordable plan that will give 7.5 million uninsured and underinsured people access to prescription drugs for diabetes and contraception. We really hope that in the future, this can be increased and expanded, as my colleague has mentioned. I think we do want an expansion of this formulary in the future. But this is a good start. And so thank you very much.
Thank you, Mr. Arango. Next, on behalf of the National Indigenous Diabetes Association, Celeste Thériault, welcome to the committee. You have the floor.
Thank you, Chair, and good evening, everyone. My name is Celeste Thériault, and I'm the Executive Director at the National Indigenous Diabetes Association that's located on Treaty 1 lands in Winnipeg, Manitoba. And it's an honor and real privilege to be speaking about this bill in front of you as it relates to Indigenous people in Canada. And a little bit about the National Indigenous Diabetes Association. We refer to ourselves as NIDA, and we're a charitable nonprofit members-led organization that was established in 1995 as a grassroots initiative for women on the side of Lake Winnipeg, advocating that diabetes was taking too much from their people. And that was almost 30 years ago. That's First Nations, Inuit, and Métis inclusive in Canada. And so this bill really provides the beginnings of a comprehensive pharmacare program for all Canadians and represents a significant step towards addressing social health inequities across Canada, including within Indigenous populations. Indigenous people, First Nations, Métis, and Inuit, and I may refer to them as a pan-Indigenous term, but representing that they are distinct nations with distinct interests, that they suffer disproportionately from the socioeconomic constraints and illnesses, as well as they stand to really benefit substantially from the provision of much-needed diabetes care, especially Métis individuals who are not covered under the current non-insured health benefits program. And so the current government of the day is really commended for this first step and including diabetes medication in that first step. That said, we should be continuing to do this in a good way. And what does that mean? That means talking with our Indigenous nations, political leaders, and individuals with lived experience to make sure that no one gets left behind. We know that changes that affect Indigenous people with Canada should be done with us, As we know, nothing about us without us. And I would like to mention that because of the short period of big decisions between the tabling of the bill and this consultation, we didn't have adequate time to consult all of our members of interest with the implications of the bill, and that our organization by no means can talk on behalf of all Indigenous nations across Canada. So there should be continuous and ongoing meaningful dialogue with many Indigenous people and nations, and especially our political leaders, and that the Minister of Health talks not only in terms of provincial and territorial governments, but also our Indigenous governments that have some sovereign rights to having their voice heard here on this legislation. So it's vital that we roll out this new program very carefully, that we really consider the context of existing benefits, particularly through the non-insured health benefits that present the right of the status First Nations and Inuit beneficiaries in Canada to provide for medications for treatment of diabetes and other pharmacological care, but not all of them. So it is at the detriment of the individual. It also remains unclear whether NIHB and the new Pan-Canadian Pharmacare program will be responsible for providing medication coverage to these individuals, but as the minister spoke earlier today, that all the programs would kind of remain in place, so we believe that that would be helpful. The coverage of medications for First Nations and Inuit can be bureaucratically burdensome, and we know this. Individuals and healthcare providers on reserve are already really administratively overwhelmed. So we need to ensure that the policy is reducing those burdens administratively so that our providers can directly impact patients and deliver patient care in a good way so that we don't need to burden individuals with getting their medications covered. We also want to make sure that there's a comprehensive list of medications allowing for both the prescriber and the patients to be advocates in the healthcare journey of their diabetes management. And of course that we want to steer away from a two-tiered healthcare system that, only the best and strongest medications are only available to those with deep pockets, with privilege and secure employment with strong health benefits. So in that same tone, we want to ensure that no Indigenous person is left behind, because having Métis individuals not including in the NIHB means that Métis individuals providing their care will have much greater access through this bill. And we have to remember that when we walk forward in this legislation. And we need to be at the bare minimum or equal at the bare minimum of equal or better than current coverage for all Indigenous people in Canada. And we must make sure that we are working together to ensure that there is that access, whether that is brand name medications for diabetes care when the generics are not available, again, supporting timely access and ease of use for Indigenous people so that, those living with diabetes can keep their healthy blood flowing now and several generations from now. And as an Indigenous woman, I'd be remiss of the opportunity to also comment on the contraceptives. As someone who had to use 3 IUDs to get my last one successfully put in, IUDs are quite expensive, and that would be not possible for me had I not had some support in place to be able to do that and make that a reality. And so that all Indigenous people are able to access whatever form of contraception they need to determine what is best for their own person, and that the funding should be provided for each of those types without exceptions, just as it should be with diabetes cares, as it's an extremely personal journey. So we look forward to a Canada where First Nations, Métis, and Inuit have equitable access to life-saving medications, although more consultation is required to move forward in a good way. We really invite further collaboration on this vital project to ensure that no one is left behind. We want to ensure that everyone from our Indigenous elders, youth, lived experience people, Indigenous nations, governments, and politicians are adequately involved in the decision-making process of this bill, not just, like I said, our provinces and territories. And let's continue to work together in a good way to ensure that we are raising health outcomes for all Indigenous people in Canada, representing a significant step step forward in addressing social health inequities
Can I get
across
you to wrap
Canada.
up, Ms. Thériault, please?
Merci. Thank you. Thank you for your attention.
Okay, thank you. Dr. Francoeur, representing the Society of Obstetricians and Gynecologists of Canada. Welcome, you have the floor.
Thank you. Mr. Chair, members of committee, bonsoir. My name is Dr. Diane Francoeur. I'm a practicing obstetrician and gynecology as well as the Chief Executive Officer of the Society of Obstetricians and Gynecologists of Canada. I'm here today to discuss the aspect of Bill C-64 that proposed to offer universal coverage of a full range of contraceptives for Canadian women. Specifically, I wish to highlight why this measure is important and long overdue, why it's not just a woman issue or a nice-to-have measure, but a necessary economic policy that benefits all of society, and why we hope as legislator, will ensure coverage of all forms of birth control are included in the final bill and that it passes without any undue delay. Today, somewhere in Canada, a woman will have to choose between buying grocery, paying her electrical bill, filling up her gas tank, or paying for her birth control. It's no secret the rising cost of almost all goods and services have become a significant burden for many Canadians. But 9 million women of childbearing age in Canada bear the additional cost of preventing unintended pregnancy, a basic need which often flies under the radar, but which is no less fundamental to the way of life of millions of Canadian women. Contraception allows women to plan their lives, their families, and their pregnancy. They are more likely to finish school, they participate more fully in the workforce, they enjoy more economic stability, and they have healthy pregnancy when they do choose to have children. Canadian women spend on average 30 years of their lives shouldering the associated cost of trying to avoid a pregnancy. But financial barriers can limit birth control options for many women, as you so highly said. Canada currently has a patchwork of coverage for contraceptive, which varies according to income and where you live. This forces some women to choose the cheapest method, not necessarily the most effective or the best method for their bodies. Or in some cases, they may not be able to afford any birth control at all. This can result in an unintended pregnancy. I see this every week in my practice. We can do better than that for Canadian women. Approximately 40% of pregnancies in Canada are still unintended. This don't just only impact women and their family, but it also affects the economy. The direct cost of unintended pregnancy in Canada is estimated to be at least $320 million per year, a figure that doesn't include the downstream cost to society or to parents. The BC modeling indicates that the health system will save $5 for every dollar they invest in contraception every year. As legislators, we urge you to ensure that Bill C-64 passes smoothly and without undue delay. To fully implement the commitments in this bill, Ottawa will need to negotiate agreements with the provinces and territories, which will take time. Any parliamentary holdup will only force women to wait longer for this much-needed assistance. Already, my patients, my neighbors, my nurses with who I practice every day have been asking me when this coverage will become available, because it's never soon enough for those in difficult economic situation. We also urge you to ensure that the final version of the bill and any budget measure attached to it include coverage of a full range of contraceptives, including the pill, the patch, the ring, the IUDs, the shot, the implant. By ensuring that all options are available, 9 million women in Canada will no longer be forced to make decisions about their family planning based on their income. Thank you.
now begin with rounds of questions, starting with the Conservatives for 6 minutes. Dr. Kitchen, please.
Thank you, Mr. Chair, and thank you, everybody, for being here at this late hour and on such short notice. It's greatly appreciated, and I think that's part of what Canadians want to see is true conversations and discussions of what this piece of legislation says and what this piece of legislation means, and being able to decipher it in a manner that the average person that might even be watching this evening at this point in time can understand what is going on and the challenges that we have. To you, Ms. Theriault, and thank you very much for your comments and your insight. One of the things in my past life, before I became a member of Parliament, I was a consultant for the FNIHB. And so I'm aware of things along the lines of providing healthcare services to First Nations in different avenues. I'm wondering if you could explain to those watching who don't understand, because FNHIB is covered by the Government of Canada. And so what you could say on the coverage for diabetes and other coverages that might be available?
Under the NIHB program, correct?
Correct.
Thank you, Mr. Chair, and I thank the constituent for his question. So the NIHB program and specific diabetes medication coverage is more extensive than the formulary list that was the backgrounder list that was circulated. And there are some disparities between the NIHB list and the Canadian practice guidelines that are published. And so they're not fulsome and not comprehensive in the first place if we really wanted to pick them apart, but they are better than the formulary list that was proposed here as a base minimum. And there are some that are only able to be covered if there are specific requirements of such. You need to be an insulin user to get a specific medication covered. So it varies in terms of all of the medications. One big one that we see that is not included is your GLP-1s. And that's something that our Indigenous people use extensively to manage their blood sugars in a way that works for them. And I think that we need to look at it very, very holistically on what it also provides outside of pharmacological care, because pharmacological care, sorry, that's a hard word for me today, is only a certain portion of what is covered under non-insured health benefits.
Thank you. So to be clear, you're basically saying that what's being proposed in this legislation is actually less than what is available for First Nations at this present time, under the understanding also that the services that are provided to First Nations are universal across Canada. They don't vary from province to province.
So first of all, it is for status First Nations and Inuit beneficiaries. So yes, for status First Nations and Inuit beneficiaries, the NIHB program currently provides more coverage. Now we are missing an entire other population of Indigenous people and also our non-status individuals within that scope. So we cannot make a sole judgment just based off that one thing, but yes.
I appreciate it. So are you, and granted you did touch on the fact that because of how quickly this came about, you weren't able to get conversations with all groups. Are you aware of whether actually the government has actually talked to First Nations about this before this piece of legislation came about?
I am not aware, and I wouldn't be privileged to that information in my current role and position.
Okay.
But I do make it clear that our Minister of Health does need to have those conversations.
And that was going to be my next question. Do you think that's an important aspect where this Minister of Health should be talking to our First Nations before we even get this out on the table?
I believe that our Minister of Health has to have conversations with provincial and territorials, as well as our First Nations, Inuit, and Métis, not just First Nations, governments, and that can be done in a good way through moving the bill forward and also making sure that, I think the minister said today that he cannot have concrete conversations with the provincial and territorial governments, that he'd be in breach of Parliament or something along those lines. So we want to make sure that the Indigenous voice is heard first and foremost.
Thank you.
And I think everyone can work together
likewise,
towards that.
As you indicated, it should be also for the provinces and the territories to have those conversations.
Of course.
Thank you. Ms. Walker, and thank you very much, and I have huge respect for my pharmacists that I have, and my own personal pharmacists, because of the advice that they provide. And a lot of Canadians don't understand the knowledge base that they have, and oftentimes they are much more knowledgeable on all medications, more so than perhaps even the doctor who's providing that information. I don't mean that disrespectfully. It's just that that's what you spend 4 years studying to become that pharmacist. Your comment about the committee, and that I find one of the things that I find very discerning about this piece of legislation, because it doesn't clearly define what that committee will be. It doesn't say how many people will be on that committee. It doesn't say what their role will be, what qualifications they need to have in there. And so your comment about having a pharmacist on that in one manner, I think is very important. And I wonder if you could expand on that.
Absolutely. I mean, I think it's very natural to think of your pharmacist first and foremost as the person who's managing your medication treatments on an ongoing basis. And they really can provide a very practical, real life view of what any changes would propose. So whether the legislation goes in any particular direction, the end result is it's going to be an interaction between the pharmacist and the patient at that counter, right? And so they need to be able to explain what the change has been, why the change has been made, and depending on how the spectrum of the changes that are considered, changing millions of people from different programs could be hugely challenging from just even a logistics and burden perspective. So having somebody like that on a committee would be essential.
Thank you, Ms. Walker. Next, Mr. Joe Harvey, please, for 6 minutes.
Thank you, Mr. Chair, and thank you to witnesses for coming. Just want to follow up on what Dr. Kitchen talked about. Just want to also thank you for advocating for pharmacists, one of my very good friends, my mentors, and the one that I trust with all my medication is Akil Dirani, who's running many practices, and I often go to him for advice on many things, especially around the pharmacare. I'll ask you a very simple question. You are familiar with, or I believe you're familiar with the plan, the healthcare plan that we have, okay? And if I develop type 1 diabetes, what would be the scenario today for me? What would be the difference today, whereas tomorrow when this bill passes? What would it be when I go to Akil and say, Akil, now I have type 1 diabetes, but it's universally available now. What change would I see from a treatment? And what change should I anticipate from my insurance provider?
Yeah, so it really depends a little bit on the treatment that you're currently using. We certainly fielded an enormous number of questions from pharmacists when the PSHCP transition was made, because there were changes that affected patients. One of the biggest one was, as you some members might be familiar, compliance packaging for elderly people. So that's a service that was provided with an understanding from the pharmacist and the physician that it was noted in the file. But now a pharmacist has to apply, or the patient has to apply, go into their paperwork, get a response back from the plan provider. And so I'm illustrating that just to mention that it can be additional processes to go through. And so the difference might be if you're on a drug that isn't currently envisioned on the list, such as the GLP-1, the question will be, will your current plan cover that and pick that up? We're also very familiar with the challenge that employers are looking to cut costs as part of their plans, right? So if it's already covered, if a drug class is already covered, they may look to reduce those costs so that they can invest in other areas of their plans. And so those are the questions that we would ask. And if you're not currently covered, and this is sort of what happened with if you're from Ontario, the OHIP Plus program that was for kids that was introduced, pharmacists had to do a lot of triaging of patients who had lost coverage for a particular drug, apply for special exemptions, and that just adds to the burden of an already existed, like very pressured profession and healthcare system at the moment.
Making it simple, if I am covered today, your concern or the pharmacist's concerns is would the amount of coverage potentially be reduced because the type of let's say diabetic medication that's made available as part of the universal. That's
Certainly.
one area that you're. The other one is if I don't have medication, at least I don't have coverage. That means at least I'm one step ahead, being able to get the medication that I need. Is that a fair summarization of what the concerns are and what the benefits are?
We've always advocated that the best way to serve patients is to help fill the gaps for people who don't have coverage or to help people who don't have enough coverage. And those are slightly different issues and need to have really tailored solutions. So absolutely, this could be a step up for somebody who doesn't have coverage, and we would support that. But in terms of the legislation, we would like to see a more explicit reference to maintaining private coverage so that it would go to that private coverage first.
You're going to make one recommendation along those lines. What would that recommendation look like?
We would look to some of the definitions around single payer and specifically coordination of benefit, which is, again, if you have a spouse, you might be familiar with a pharmacist having to coordinate, first apply to the one spouse's plan and then coordinate with the other spouse's plan so that you don't have to pay out of pocket, but to do so with a way that the private plan is charged first and then the public plan picks up the remainder of the difference if there is one. And if you don't have coverage, then the public plan would jump in first.
Okay, thank you. With my remaining time, I'm going to go to the Society of Obstetricians and Gynecologists of Canada. I'm developing an understanding of many different contraceptive that's available and how it fits best depending on the situation. Can you give us a sense? And I think you touched on it. Can you explain further the fact that this current scope is covering a broad range of contraceptive and supporting products? IUD was mentioned as one of the items in one of the panel. I think it's on the first panel. Can you expand how is this helping Canadians, especially women, who want to have that choice to be able to plan their life better?
Absolutely, and thank you for this question because it's really, really important. And I'll give you two quick examples that are easy to understand. In 2006, I was at that time president of OB-GYN Society of Quebec, and we made representation to the government to have the hormonal IUD covered. That was a long time ago, 2006, and in other provinces, it's still not covered. And you know, these methods have been doing an amazing change in the teenage pregnancy rate because they are very, very effective. And once the IUD is there, it's there to stay. Now we can leave it up to 7 years unless the woman wants to remove it. So every one of these methods has some advantages and some side effects that sometimes adolescents or women don't like. And that's why we, you know, by having all medication coverage, it's going to really help us to fit the need. But as you said, because, you know, I have a Canadian position, and my heart is broken when I hear that, because since 2006, we've been putting IUD, and then women are happy, decrease the rate of hysterectomy because there's a lot of good side effects like decreasing the bleeding. It changed women's lives. So that's a good example of what needs to be done.
Thank you, Dr. Francoeur. Thank you. Monsieur Blanchet-Chonka.
You have 6 minutes. Thank you. And thank you to the witnesses for being with us tonight. My question is for Ms. Walker. You mentioned that pharmacare wasn't just about cost, but about the care that is provided. Could you talk about that a little bit more in detail? Certainly. Not all drugs need advice from a pharmacist, and The work behind the counter is very complex, though. Pharmacists can talk to patients about the interactions and make sure that patients have the right medication. They can go over the medication and look at the other medications that are being used by the patients. And more, we know that pharmacists are providing primary care. Thank you. You also talked about your concern about the medications that are covered. We have had a program in Quebec for 30 years, and many are familiar with that. There are about 2,000 drugs that are covered. It isn't all of them, but do you feel it is reasonable to actually examine the concerns that have been raised by doctors and others? A report showed that the formulary used in Quebec was the most complete of any across the country. So the risk of losing coverage for people increases if we move from a private sector to a public sector plan. So we need to look at what the list would be, and if we look at medication for heart disease, for example, for those who don't have it, that might be a good way to go. Do you have any advice to give about not losing coverage? The bill, in fact, is a bit vague about private plans. If there were clarifications, it would be helpful. The minister seemed to be saying today that private plans would be protected, but there's no mention of that in the legislation, so that would be something to improve. I share your concern. I find it a little confusing and a little surprising. It would be better to prevent this problem than to try to fix it after. The federal government has given us an overview of what it wants to do, but what would the impact be on pharmacists, even if we don't have all the details? Yes, we don't have all the details, but I could talk about the time impact. There are going to be major changes that will have to be communicated. The government is going to have to include the cost, the differences between the private and public plans, because pharmacists will have to be able to continue to provide the advice. The difference between the public and private plans is quite significant in Ontario. For example, the dispensing cost is much lower than at the national level. So there would be a major impact in that case. And thank you. On your website, your association indicates that the provinces and territories manage their health systems, and that it would be better to avoid creating a whole new plan, but rather increase coverage for those who are uninsured or underinsured, so that we would have a mixed system. Clearly, the various provinces are at a very different starting point. In Quebec, there is already a plan. It may not be perfect, but in BC, for example, there is no plan. So we think that the biggest impact right now would be to identify in each province how their programs could be strengthened, and because the needs in each province are not the same. When we talk about moving from one type of plan to another, could you talk about the possible problems? Well, I can certainly give you some examples. When we had a transfer in BC to a new type of program, the NHIB lost about 17% of the coverage, and so reforms had to be made, would have to be made to make sure that people don't lose their coverage. We've got OPIP Plus in Ontario that was created to help cover children. People had to come into pharmacies to come into their medication, and then they found out that the medication they'd been using was no longer covered because there was less covered. There was less coverage for what they had been using. We also are still using faxes in many cases. Thank you.
Please, for 6 minutes.
Merci beaucoup, Monsieur le Président.
Thank you, Mr. Chairman, and thank you to our witnesses who have provided very important testimony. The Quebec system has been talked about a few times. A few hours ago, a major coalition in Quebec representing 2 million Quebec residents called on Parliament to adopt this bill, C-64, saying that the organizations represented, that is, the major unions, health care groups, consumers groups, and others, have said that the current Quebec pharmacare plan does not provide fair and universal access. And in fact, there are deductibles that dissuade people from buying their medication. They can't afford to get their medication. There have been increases in drug costs that have put increasing pressure on people, and in some cases they have lost their coverage. So obviously the pharmacare plan in Quebec isn't working well, and all of these organizations are calling on us to adopt this legislation. So my question is for you, Dr. Francoeur. What does it mean for women to have universal access to be able to ensure their own reproductive health? What does it mean for women when they can't afford the medication they need? The big advantage is that we can stop talking about money in this context. We can talk about the advantages for a given person. We would like to have the same model as in BC, but patches, for example, were not included in the BC model. If there was a bariatric surgery, if there are problems with absorption, then the patch will not be as effective, or other means might not be. Maybe a patch would be the best method. So there are various circumstances which call for different medications in Ontario. Young women were studied, and it was shown that unintended pregnancies resulted because women did not have the choices, for example, for an implant or other types of interventions. And I have worked in Quebec. I work there, and it is not the case that people have full choice. Women do not have full coverage. It depends on the coverage that their parents have, and that means that there is an extra step involved in protecting young women from unintended pregnancies.
All of your testimony was very important. I was particularly touched by your speaking about heart and stroke, the 600 Canadians that die every year because they can't afford to pay their medication. And what I hear you saying is that we can't stop with diabetes medication and contraception. We have to move as quickly as possible to cover heart disease and medication that prevents strokes. I know of constituents that are paying $1,000 a month for heart medication that keeps them alive. They have to make that difficult choice every day. Do I put food on the table? Do I keep this roof over our family's head? Or do I stay alive? What impact would it have if universal pharmacare was extended to all the medication that Heart and Stroke Foundation and the research prescribes for people with heart and stroke issues?
It would be very, very significant because, as I mentioned earlier, there is a significant 16% in fact, of the 1.6 million people that live with heart disease and stroke cannot afford these drugs. And what they end up doing is splitting pills, skipping doses, not renewing their prescription, or not even filling the prescription in the first place. So what happens is, of course, if they don't have proper access to those drugs, they end up going to the ER, and then it's much, much more expensive to treat. So, I understand that Rome was not built in a day, and this first step won't cover necessarily CBD drugs, but in the future we would like to have that covered. But I should mention as well, though, is that someone with diabetes has a threefold increase in the risk of dying from heart disease. So it's an important comorbidity for heart disease and stroke, diabetes. So addressing that as a first step is really key. And if I may, I really would like to address the point of regarding the potential threat that's been raised of loss of coverage through private and provincial plans. The reality is if the government is providing the federal government is providing a generic diabetes drug, I do not believe that for the person that needs that drug, that they're going to care whether it comes from a private plan, a provincial plan, or a federal payer. As long as they get that generic drug, they're going to be happy, in my opinion. Now, of course, they would be very concerned if we had brand drugs that address adverse effects for them being removed from the private plan or the provincial plan. I can't see that happening. The demand would be really great to have that brand drug coverage in those private and provincial plans. So I don't think it's a very realistic scenario that those drugs are going to disappear.
Thank you, Mr. Orango. Thank you. And next, Ms. Goodrich, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all to the witnesses for being here today. Celeste, I really appreciated as you were sharing in your testimony talking about doing things in a good way, and it was very reminiscent of the many conversations I've been blessed to have with many of the elders in my region of how the intention has to go and match with the steps. And so the fact that you have been unable to consult with all of your appropriate stakeholders prior to doing that, do you believe that we have put you into a space where you perhaps are not moving in a good way, even just having to be here on such a short timeline?
No, because anytime an Indigenous person has an opportunity to raise their voice and their opinion when it's been chronically neglected through our colonial structures and systems, we must take that opportunity to voice those concerns. And I really, really hope that every bill looks at the Indigenous component, whether that's pharmacare, whether that's any other thing that the House is trying to pass.
And I appreciate that. And I guess what I was trying to ask was, would you have preferred more time to have been able to consult with a variety of stakeholders to assess the impacts of this bill prior?
Not necessarily. We have done an extensive amount of work on talking to people about diabetes through some specific work of Bill C-237 with the framework. NIDA is actually leading the Indigenous engagement for diabetes in Canada regarding that bill. And so we have been having ongoing dialogues ever since I guess we signed with the Public Health Agency of Canada on July 7th, 2022, I believe, and I got to NIDA in October of 2022. So ever since that day, we have been having those conversations, hearing about people and what our healthcare system can provide and what is it current providing, and that is information that is on our website, and it is a report, and that is a first step because we need more, and we're working on that.
No, and I appreciate that. When was your association first consulted on this bill?
So we were not first consulted on this bill. I actually had to make sure that I had a spot at this table to raise my voice. So I will make note that we do have gaps, and I think that I can't comment on all the other pressures that people want to have their voices heard, so I think it's a privilege to be here.
And I'm grateful that you are here, and I am grateful that you are raising your voice, and it's always wonderful to me to have a prairie voice at the table. We don't often have them here in person, so I'm trying not to say anything negative. I'm more trying to figure out, so you had to fight to get here. The government didn't reach out, even though you guys are the leading voice when it comes to diabetes for Indigenous people in this country, and you had to fight to be here. Is that correct?
Yes, but we also have Indigenous politicians and leaders in governments that do some politics work that our organization doesn't necessarily do. We come from that grassroots perspective to making sure that, we're not leaving anyone behind.
Mr. Orengo, when was your association first consulted by the government on this particular bill?
So admittedly, we did reach out to the department, Canadian Drug Agency, Health Canada, to discuss this issue well over a year ago. So we did initiate the contact, but I think members of civil society, we often have
Could
to
you
initiate
share
it yourself.
who in the department you reached out to a year ago?
So some of the folks that appeared earlier on, sorry I wasn't here, but we did reach out to Michelle Boudreau and her colleagues and others, and we've had quarterly meetings with them. But once again, as I mentioned, we initiated the contact, but that's our job usually as people, members of civil society.
Minister Holland often talks about his experience with Heart and Stroke Foundation. Did you work with him when he was at the Heart and Stroke Foundation?
Yes, many, many years ago. That was 2015, briefly, for 2 years maybe, yeah.
Okay. Have you talked to him specifically about this bill?
Not the minister. I don't, I talk to people in the department, I talk to people in the minister's office, and I talk to MPs, but I haven't talked to the minister directly.
Wonderful. And Ms. Walker, same question. When was your association first consulted on this bill by the Department of Health?
I think I would probably share some of the same observations, is that we engage regularly with the department and we reach out when we see certain areas. We've been active on this file for many years, and we've discussed it regularly with officials at both the political and department level.
Thank you, Ms. Walker. Thank you, Ms. Goodridge. Next, Mr. Nakvi, please, for 5 minutes.
Thank you very much, Chair, and thank you to all the witnesses for being here, and I really appreciate your testimony. I'm going to start with Dr. Frank Kerr. Thank you for being here. One of the areas that I'm hearing a lot around in my constituency, I represent Ottawa Centre here, downtown Ottawa, is around contraceptives and how this bill ensures that contraceptives are available for women, gender diverse people who need contraceptives, and takes that cost barrier away. I recently had a conversation with Planned Parenthood here in Ottawa as well, and they raised some really important issues as well. From your experience, can you talk to us a little bit about the importance of making contraceptives available the way we're proposing to do, and the kind of impact that it's going to have on the lives of women in Canada?
Well, thank you for that question. It's we've been lucky in a way that BC started before, so they've been covering contraception for a year now, and all the good news that we hear about it's obvious that it's making a change. So we're just eager to know all the numbers and the result associated with this coverage. But obviously, money is a big issue, and women. We were talking about the Quebec model. We see that women delayed when they have a part of it, because someone mentioned it with the prior group. It's still a lot of money. Nothing is free. I mean, in Quebec, don't have any expectation. Nothing is free. They still have to pay a part of when they go on a monthly basis, and sometimes they wait, they postpone, they want to make sure that they're going to take all the medication at once to pay just the minimal of the coverage. So all of these actions are burden to make contraception less effective and promote unintended pregnancy. And there's a cost for that. There's a cost for the future of Canadian women, because we know that when young people have a baby at a younger age, they're more likely to stop going to school, and this has an impact on all of us, because there's a cost associated with that we all pay as well.
We've been talking a lot about the social impact of having contraceptives available to women and girls. We've talked about examples where a young woman may not want her parents to know that she's using contraceptives, and by using private insurance, there's a notification where the parents may know. And so I think we have a good understanding around those impacts and the freedom that this type of measure will give to women and girls in Canada. Can you speak to, from your experience on the health side, as to the kind of impact this access, by breaking down this barrier, means for the health of women and girls in Canada?
Between 15 to 20% of women have really many problems related to their period. It's going to be hemorrhage, so they're going to be bleeding problem that they are carrier. It could be endometriosis where they have pain. So obviously, when they are on a hormonal contraceptive method, these symptoms are all alleviated. So it's a good side effect of these drugs that we can use. But unfortunately, sometimes they're just not gonna be able to afford them. We had a lot of new immigrant women that are not covered by all our refugee coverage, especially in Quebec in the last year. And I can tell you, it is a burden. They don't have any money. Not at all. Not to pay the cheapest method that they could get. And, an IUD is going to be at least $450, $500. That's a lot of money. It is a lot of money. Even if you keep it for 7 years, it's going to be cheaper. But that makes a big difference. So that's why we want to make sure that these newcomers are going to be able to settle, learn the language, become Canadian, and then plan their family and their pregnancy instead of being surprised by an unintended pregnancy because they were not able to offer the contraceptive that they wanted.
Do you see a lot of stigma around cultural stigma, social stigma around sexual health of women?
Absolutely. Absolutely. And we are afraid of what's happening at our neighbors down the south, and we think that we have to make sure that all Canadian women will have a right to be questioned and engage in their sexual reproductive rights.
And that's a really good point, because we're so influenced by what happens in the United States. Sometimes that perception becomes, people think that's the reality in Canada. I've heard from so many people when we saw Roe versus Wade being overturned in the U.S. that they thought that was the case here in the U.S., in Canada as well. So we have a lot of hard work in terms of creating that education, that safe space for women where they can be free sexually
Thank you, Mr.
from the health perspective. And hopefully this does that. Thank you.
Thank you. Monsieur Blanchette-Chonka pour 2 minutes et demie.
You have 2.5 minutes. Thank you. I want to come back to my questions. Ms. Dr. Francoeur, thank you for being with us and your commitment to help in Quebec. I know that you were for 7 years the head of specialist physicians in Quebec, and you have a great challenge, and I congratulate you on it. I'm trying to understand how we got to this pharmacare plan. I know when you were heading up the specialist physicians organization in Quebec, you were in favor of the plan we had, and we reduced our costs, and we reduced it from 6 billion, we reduced it by 900 million. So, but if we don't increase health transfers, maybe that wouldn't resolve all of the problem. But if we can provide a better pharmacare plan like we have in Quebec, do you not think it needs better health transfers? Well, those are excellent questions that have to be looked into. Nothing is free, and it's the difficulty with Canada. In my work, I work with other countries, for example, England and others, and our system is very complex because we have a federal system. We have the provinces that administer healthcare. We are the last OECD country without a pharmacare plan, and it has an impact on Canadians. Do you know that in Canada there are still women who die in childbirth? Well, thank you. I certainly am not trying to embarrass you, but you have a new position now. You understand the pharmacare plan in Quebec, but what can the federal government do that the Quebec government can't do already? Well, without going into all the details and revealing any secrets, I think that we can certainly look into improving the Quebec plan. We know that a lot of systems are different. In fact, daycare has been a very difficult sell in Ontario, trying to get women back to work by having good system, and we've seen so many emergency rooms have to close. We have to enable women to get back to work. Thank you.
Thanks, Mr. Chair. I'd like to come back to you, Ms. Theriault. Thank you so much for being here. I asked a question earlier about to Mr. Blesky, who is a witness who is diabetic, and what would happen if he was unable to take his medication. It was horrific what he described. I don't know if you were present and heard his testimony. I'm wondering what the impact is. If you mentioned and flagged specifically Métis people, non-status Indigenous people who don't have access to medication right now, what is the impact if you do not have that medication? And what would be the consequence positively of having a large number of Métis people, non-status Indigenous people, actually getting access to all of the diabetes medication and devices that they're prescribed?
Yeah, thank you, Chair. And through you, I think the question, I think it's important to note that I don't live with diabetes, although it affects many of my family members, and we are Red River Métis. And so what I see in my personal network of my family is that people, they don't live with type 1, and I did hear the testimony earlier today, but they do live mostly with type 2 diabetes, and it's extremely hard to get a CGM covered when you're under type 2 diabetes, by the way, but that's what we know is causing so that you don't get your calloused fingers, so that, if you have a desk job and you're typing all day, you're able to just check, monitor, you have better in-range time of your blood sugar levels, but also we see it in insulin because some people will insulin ration as well just to make sure that, they can put food on their table. And I don't think that's a choice that people need to make when it comes to their health. And I think that people should have access to the things that they need in a timely manner for them to be able to manage their health in the way that they need. And that's Métis, non-status, status First Nations, Inuit beneficiaries, all encompassing.
How many, do you have an estimate on how many Métis people, non-status Indigenous people would be helped by having this universal access that can't access it now through the NIHB, of course?
So I don't have specific numbers, but I have some percentages here in front of me. And Métis, and this is some older data because we struggle with some data points and data collections and gathering data from some governments sometimes. So it's currently at 7.3%, but let's be clear that that is some 2010, and that on the most recent 2022 Framework for Diabetes in Canada report did state that it has found an increase in the prevalence of diabetes across all Indigenous populations since 2012. It didn't specifically outline the percentages. So Métis was 7.3%, and the we don't have the non-status because they get lumped in with non-Indigenous people because they're not recognized under that. But I would refer to probably some of the organizations that do work on behalf of non-status people to answer that question, and I can make some inquiries to see if we can get some answers like that.
Thank you, Ms. Theriault. Next, Dr. Ellis, please, for 5 minutes.
Thank you very much, Chair, and thank you to the witnesses for being here. Ms. Walker, you're a pharmacist, and you're still working as a pharmacist. Is that true?
I'm actually not a pharmacist, a practicing pharmacist. I work for the Pharmacists Association and with those members to navigate some of the issues that they encounter in their work.
Great, thank you for that. One of the things that's not captured in Bill C-64 is something Canadians have relied on now for many years, and of course that's the expanded scope of practice in the professional life of pharmacists. And is that something that you think should be captured in this bill?
Absolutely. I think there's many services that pharmacists are delivering now to Canadians across communities. In many rural and remote parts of the country, the pharmacy is the closest access point that they have to health care. And so pharmacare, as we sort of mentioned, isn't just about sort of like the cost of the drug, but really the care that goes around it. It'd be like dental care without dentists. And so we absolutely see that. And increasingly, pharmacists are doing a lot more to serve their communities.
Well, I was going to say something smart, but there is a dental care program without any dentists. So anyway, that's a whole other issue. It's interesting, though, especially when we're talking about diabetes, because, of course, many pharmacists are diabetes educators, which helps diabetics better control their blood sugars. And often there is a cost now built into provincial plans and private plans to pay for that. But this bill in particular doesn't capture any of that cost. And do you think on behalf of your members that would be an important piece to have as part of this legislation?
There are a number of different services that are associated to drug management. So clearly there's the dispensing aspect that, make sure that the person is getting counsel, that they're getting their drugs safely and effectively, that there's no drug interactions with other things. And then there's things like medication reviews for people who, might be on multiple medications, and appropriate use is really important. We know that many aging Canadians are taking medications to address a side effect of another medication. And that's an unfortunate way to live. So for certainly smoking cessation, diabetes management and care, hypertension, there's been a lot of evidence showing that those services provided by pharmacists actually improve the quality of life of Canadians and also the use of those medications.
Now, It's interesting, Ms. Walker, you talked about looking at the plans and this concept of universal single payer program that's introduced here in this bill. And in your experience on behalf of your membership, would you suggest that that would mean that the federal government would be the first payer? Is that not true?
Some of the questions that we've so far heard and have posed ourselves is how, that's interpreted in the legislation. And I think for what we're looking to see is a clearer definition of which payer would come in and whether there will maintain a private payer. And I think a number of the provinces that have spoken publicly on this issue have also raised that they would be looking to add to their current public plans, but while maintaining sort of the private aspect that they have in their jurisdiction. So really would come down to some of the negotiations that would take place. But the legislation, we would recommend that there be clear reference to a mix of public and private payers to make sure that that's maintained looking forward beyond even diabetes and other potential medications that might be under consideration.
So what I've heard you say is that would be an incredibly important part of our rapid deliberations, which must happen by Monday in our clause-by-clause consideration of this bill.
Yes, I think we would support that, absolutely.
Great, thank you. One of the things that has been talked about here in this last panel a bit and in previous panels is semaglutide or Ozempic, which is a drug obviously used to treat diabetes. It's been an absolute blockbuster drug. Do you have any information for the committee with respect to the cost on a monthly basis of Ozempic or semaglutide?
I don't have that number handy, but I will share a couple of examples that might be helpful in your deliberations around Ozempic. It's obviously not covered under the proposed list of medications that's widely used. We've recently had a shortage of Ozempic across the country, and my association works very regularly to address shortages that are a growing problem in the country. So when we talk about pharmacare, it's not just about the cost of drugs or the services that are being offered, but if that medication is not available in the country, there's no amount of coverage that's going to help that. And one of the things that we've noted certainly is the number of available medications in each drug classes can decrease significantly depending on how many companies are on the market, and we are most vulnerable to drug shortages if we only have one or two manufacturers producing a particular drug. Say if there's like a national disaster in one country that's producing some of the API and the one company can't produce that drug, the other companies aren't able to readily increase their production, and we've really suffered significantly with many shortages. So there's a really complicated, I think, ecosystem that this pharmacare approach needs to also recognize.
Thank you, Ms. Walker. Dr. Ellis, the last round of questions for today will come from Ms. Sidhu. Next 5 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for being with us. My first question is to Ms. Terrio. With the dental program, we know the 100,000 already within 3 weeks Canadian get benefit, and then 1 million already registered. But with this legislation, could you elaborate what are the biggest barrier are the Indigenous people seeking care for the diabetes prevention? And with this legislation, what do you think with the contraceptive care? Do you think it will be benefit to the Indigenous people?
Yeah, certainly there's going to be benefit to Indigenous people, and that's without a doubt. I think to comment on your first question is that we need to also ensure that we are making holistic, with a W for the note takers, decisions around public policy that affects our health, that doesn't just look at, the pharmaceuticals and all those things. And I know we're here specifically for the pharmaceuticals, but there are so many other things that impact that, socioeconomics, social determinants of health. And so I think this is the first step in a right direction for, opening up the conversation and the dialogue to all of those other sectors that obviously this bill does not cover. And of course, Indigenous people, if their medication cannot be covered, most likely cannot afford to even take the medication. They may not even just get the prescription filled, as we know. And I think that'd be interesting data to look at, as well as making sure that, they're going to feed their family first or do whatever they might need to do first for their own health. And often we're faced with that every day, that decision and that hard decision. And if you place yourself in, I know my chair often speaks very openly about the ideal type of diabetes treatment for herself as a type 2 person living with diabetes in Alberta is currently not available to her because of the lack of coverage, and it simply would be way too expensive for her and her family of 6 children to afford. So therefore, it is just not an option, and she has to look at other alternatives.
Thank you. And my next question is to Dr. Franker. Dr. Franker, you talked about the teen pregnancy and sexual reproductive health. So could you outline what the biggest barrier are for Canadians seeking contraception, and what would you recommend to combat this?
Well, first of all, I think that cost is definitely one of them, especially choosing the long contraceptive like the IUD, the patch, and this is the finance around it is really the biggest one. But second, there's something that we don't talk enough. Also, it's the coercive aspect of contraception. You know, a woman will pay for 30 years, and if she doesn't have money to pay herself, it's going to be her partner who hopefully should share part of the bill, but we don't see that. So unfortunately, when once again money is being brought during the conversation on which method they should choose, it has an impact. So if women are allowed to make their own choice and they don't have to beg to have help to pay the contraceptive method of their choice, that's going to have a huge impact on their self-esteem and they will feel more respected.
I agree that the old contraceptives are not solely just used for pregnancy prevention, and there's other health concerns is there too. Then we can reduce the healthcare cost in that too.
Absolutely, because you know, even if we want that every woman can choose the method of her choice, you know, some women, as I said, 15 to 20% of women will have problem with pain, with bleeding, with fibroids that may grow over time, and so using a contraceptive method will use it as for the side effect, because we know that it's going to treat the problem. So it's absolutely an added value for these women.
Dr. Rango. Dr. Rango, in your submission, the heart disease has been the second leading cause of deaths in Canada across all ages in the last decade. And millions of people in Canada live with heart disease and rely on prescription medication to help keep them alive and to manage their condition at home. However, many cannot afford them. So what do you think? Do you have any recommendation for how people with diabetes can reduce the risk of heart disease and stroke? You already mentioned there's a comorbidities of diabetes threefold more. So what is your recommendation for that?
Certainly in terms of reducing your risk, I think a lot of people will know, obviously being physically active, not consuming tobacco, and having a good diet is going to be huge. It's going to be very important to reducing your incidence and probability of developing heart disease, stroke, and diabetes. And I would just add another point, which is that, as mentioned earlier by my colleague, that social determinants of health also have a huge impact. So socioeconomic status, access to water, clean drinking water, and to a safe environment also are very important. All those factors, and actually access to income as well, is very, very important. So all of those factors play into the likelihood whether one will develop diabetes or cardiovascular disease.
Thank you, Ms. Sidhu. Thank you, Mr. Arango. And thanks to all of our witnesses for being with us today and for your thoughtful and patient testimony. Don't run away, colleagues. We have a budget to deal with, but to all of you, thank you so much for being with us. A budget has been circulated for the work to be done on this study. that you would have received either earlier today or yesterday. Is it the will of the committee to adopt the budget as presented?
Yes.
Any discussion? Okay. The budget is therefore adopted. Is it the will of the committee to adjourn the meeting?
Yes.
We're adjourned. Thank you.